Good morning, everybody. I'm Mike Clegg, Dean of the school, and I want to welcome you to this symposium, Measles Rises Again, the Science and Policy of a Preventable Outbreak. I want to give a special welcome to our speakers who have taken time from their busy schedules, and some have traveled quite far to come to our school today. ABC News' Dr. Richard Besser, retired U.S. Representative Henry Waxman, CDC's Jane Seward, Red Cross's Luke Reeves, and public health officials who are working on the front lines like Laura Herrera-Scott, Leanna Wen, and Greg Branch. I also want to thank our new Associate Dean for Public Health Practice and Training, Dr. Josh Sharfstein, and Professor Neil Halsey for organizing this conference in the past week. I'd also like to thank our own measles experts and vaccine experts who you'll be hearing from shortly. And to our Office of External Affairs, a special thank you for their help and leadership in having this conference put together in such a quick time, especially Associate Dean Josh Else and Stephanie Desmond. Previously, we've held symposia on gun violence, prescription drug abuse, and Ebola. And from these experiences, what we've learned is that it's incredibly valuable to convene a group of experts to bring science and science-based solutions to solving urgent public health outbreaks. Clearly, the current outbreaks, driven by a highly infectious virus and fueled by micro-communities with low vaccination rates, is just the kind of public health challenge that calls out for the best science and the best evidence-based responses. A few statistics will bear out the severity of the current outbreak, which has infected more than 100 people in 14 states, most of whom had not been vaccinated. Ironically, since the CDC announced in 2000 that measles had been eliminated from the U.S., cases have been creeping upward, with more than 600 in 2014, the highest number reported in 20 years. And as we know, this current outbreak is entirely preventable. The measles vaccine was introduced in the U.S. in 1963, and the MMR, measles, mumps, and rubella vaccine, has been available since 2005. We all know the problems of vaccine hesitancy due to completely discredited research that linked the MMR vaccine with autism. So in addition to talking about the measles virus and its history, our experts will focus on vaccine safety, vaccine hesitancy, and vaccine policy. Today, we're primarily focused on the current preventable outbreak in the U.S. It's important to note that measles remains a global scourge. In 2013, there were 145,000 measles deaths globally, about 400 deaths every day. Most were children under age 5. Although measles vaccination resulted in a 75% drop in measles death between 20 and 2013 worldwide, there's still much to be done in the world and here in the U.S., and that's why we're here today. I'd now like to welcome Dr. Josh Sharfstein, Associate Dean for Public Health Practice and Training at the Bloomberg School, to the podium. Thank you.
Thank you very much, Dean Clegg. It's a pleasure for me to be here. I want to say that it is really a tribute to you that the school has been able to pull this together so quickly. I think your vision is not just that schools of public health are developing the knowledge that is going to make tremendous changes over a time period of years, but can actually bring knowledge to bear on critical issues that are facing public health today, and I think this is a great example of that. This is going to be a really interesting morning, and I think people who are watching, either on webcast or in the room, are going to not only learn a lot, but have some of their thinking challenged on some of the really important issues related to measles. We have 4 terrific people from the school that you'll hear from, whose research bears directly on the challenge that's facing the United States now with the measles outbreak. We're also going to have 4 tremendous visitors from public health in the city, the county, and the state, who are going to talk about what they're doing to prepare for a potential measles outbreak. And we're going to hear from Congressman Henry Waxman, my former boss, who has been in the middle of the fights over vaccination funding and politics for more than 40 years in Congress. I think that's going to be extremely interesting. So it's my pleasure to introduce the moderator for today, Dr. Richard Besser, who is the ABC News Chief Health and Medical Editor. He is also a pediatrician who trained here at Johns Hopkins. You may know him from his incredibly interesting and valuable reporting around the world and in the United States on Ebola, on other international health challenges. You may not be surprised to know he's won many awards for his reporting and his work, including the 2011 Dean's Medal here for his public health contributions. I know Dr. Besser. I met Dr. Besser when I was at FDA as the acting commissioner, and he was at CDC as the acting head of CDC in the middle of H1N1. And I was just new on the job, and the calm voice on the other end of the line was Dr. Besser's. Together, we worked on a number of important things, such as emergency use authorizations for both medications and diagnostic devices. I can say personally that he is not just somebody who comes across well on TV. He is an incredibly devoted, dedicated clinician and public health professional. It is actually an incredible good fortune to public health that he has the position that he does. I think that we'll all be learning today from his background as well as his moderating skills. So, Rich, thanks so much for coming.
Thanks very much. It's a real honor to be back at Hopkins to moderate this session. I was in clinic on Friday. I still work a half day as a general pediatrician, and the receptionist said, you know, Rich, you have a call on line 1. It's a mom who thinks her child may have measles. And as a general pediatrician in the United States, to think that in 2015 I'd be receiving that kind of call, it just blew me away. So I talked to her. Her child had a runny nose, had fever, had a cough, and had a rash. And I said, okay, you know, send me a picture. She sent me a picture. It looked like it could be measles, could be a different virus. The health department was contacted, and they'll do testing. I trained here at Hopkins in the late 80s when there was a resurgence of measles. Dr. Halsey and I were talking. There were cases here in the hospital when I was a resident. I worked for Hopkins for a year in Bangladesh in 1990 and saw a lot of measles. But I have to tell you, I haven't seen measles in the United States since. And what we're going to be talking about today is why is that happening? What are the underlying factors that have allowed that to occur? What will it take to get this under control? And hopefully this session will provide some of those answers. We're going to have a large audience out there watching on the web and listening. And we want questions from all of you here in the room as well as those who are watching from afar. And there are going to be 2 panels this morning, and during those panels I'll be posing the questions that you provide. And so I want you to, in the room, write those on the cards you'll be getting and send those to the aisles. If you're watching from elsewhere, there is a email address for you to send it into. It's jhsph.events@jhu.edu. If you send your questions in there, I'll make sure that we get to some of those as well. The first speaker this morning is Dr. Diane Griffin. She's professor and past chair of the Department of Molecular Microbiology and Immunology here at the Bloomberg School of Public Health. She's also professor in medicine and neurology at Hopkins School of Medicine. She's a virologist widely recognized for her work on the pathogenesis of viral infections and the determinants of outcome and host responses to infection. Her studies have focused on measles. She's one of the world's leading experts on measles, specifically how the immune response to measles is related to encephalomyelitis. And she'll be talking about measles, the virus, the history, the disease. Dr. Griffin.
All right, well, thank you very much. If the introduction here is to know a little bit more about measles per se, and that's what I'm going to cover. So it's a rash disease that, in the absence of vaccination, is primarily a childhood rash disease, although we now are seeing it more and more in older individuals. But it remains one of the 10 most important causes of death in children due to infectious diseases. Our early knowledge of measles epidemiology came from studies of a physician, a Danish physician, who was called to measles outbreak on the Faroe Islands. And prior to much contact between island populations and the mainland, the populations were too small to maintain measles, measles in the population. So that what he noticed just from observing the outbreak was that everybody, the last outbreak had been 60 years before. Everybody who was born and was alive at the time of the last outbreak was protected from measles. Everybody who had been born subsequently basically got measles, and it had a 14-day incubation period. So he observed that there's lifelong immunity to reinfection with measles, and there's essentially 100% susceptibility to the virus. So that very high rate of infectiousness is part of the issue with respect to control of measles, and you'll hear more about that later. But the R-naught value here is approximately how many people, if everybody were susceptible to measles, how many people would develop measles having been exposed to one individual. And that number for measles is 12 to 18, which is very high, it's much higher than many of the other viral diseases that are listed on this slide. So it's incredibly infectious. That means we need a high level of immunity in a population to prevent the kinds of outbreaks that are occurring right now. So prior to measles vaccination, there were estimated to be 5 to 8 million deaths per year due to measles. And with the licensure of the vaccine, there was a dramatic decrease in the number of cases and then also the number of deaths due to measles. So you'll hear more about the vaccine, but it has had an incredible effect on decreasing the number of cases of this disease. Now, the virus is an RNA virus. It's an envelope virus. Its picture is here. It's related to a number of other viruses that cause species-specific disease. So this is a human virus. It really only causes disease in humans. And another virus that you may be familiar with is canine distemper virus, because we also vaccinate dogs for that very serious disease, which is a relative of measles. And so it has on the surface, there are two proteins that you can see, the green one and the blue one on the surface, which allow the virus then to infect other cells. And it does that, since it's an envelope virus, it does that by fusing with the cells that are targets for infection. So the attachment protein, which is the green one, or the hemagglutinin, is a target for neutralizing antibody, which is one of the main mechanisms by which we develop protective immunity and become immune to subsequent infection with this virus. Because those proteins allow for fusion of the virus with the infected cells are also expressing those proteins on the surface, and the kind of effect that measles virus replication in cells has on cells is to allow them to fuse to each other, so that you get the formation of giant cells, which are most easily seen on the right here. Pointer is not working. So most easily seen on the right, where you can see lots of nuclei within a giant cell, and the yellow staining is the measles virus protein. So there's this, and this kind of pathology is seen in the lungs of people who have measles, and also the lymphatic tissue of people with measles. So the virus is spread by the respiratory route. So you inhale virus that's either suspended in air or is in droplets that have been sneezed or coughed out. And the basic pathogenesis is described here, and we'll just highlight a few facts. First of all, the virus replication starts in the respiratory tract, but then it spreads systemically. So it spreads to primarily lymphoid tissue, but also to the skin, because you eventually have a rash, to liver, etc. So it's a very widespread infection. And during that period of time, the disease, the infection is essentially asymptomatic. The virus is spreading rapidly throughout the body, but the person doesn't start feeling sick until later. The symptoms in the second panel there are mainly the rash, and a little bit prior to the rash are some fever and cough, etc., that may occur. That rash is a manifestation of actually the immune response to the virus. So it takes that 10 or 14 days to actually be able to develop an immune response that then allows the virus to start to be cleared from the body. So one of the early manifestations are these Koplik spots, which is the little white spot. I don't know if there's any, oops, back. No, dear. Well, anyway, Koplik spots. But the complications, I don't seem to be able to reverse things here. There we go. So Koplik spots are an early manifestation, so sometimes before the rash, measles can be diagnosed with fever and observation of these Koplik spots. If you look at the rash itself, then as I said, it's a manifestation of the immune response. So it's a bumpy red rash, and in that rash, if you biopsy the rash and look to see what's there, there's measles virus infected cells, but there's also lymphocytes that are specific for the virus that are responding to the virus and eventually clearing the virus from that tissue that then allows recovery from infection. But as I mentioned, it's a cause of death, and that's not the case for most childhood rash diseases. So it's a much more severe rash disease than many others, rubella, for instance. And the causes of death are these kinds of complications. So the top three are diarrhea, otitis media, and pneumonia, are actually all complications that are primarily due to other infectious diseases. So people recovering from measles or with measles are more susceptible to other diseases that then require antibiotic treatment, et cetera. So the deaths are most often due to pneumonia, and those are usually bacterial pneumonias. But in addition, there are neurologic complications. And so encephalomyelitis is an autoimmune disease and was one of the driving forces for development of a measles vaccine. Because even though it only occurs in 1 in 1,000 individuals, the likelihood of having very long-term sequelae, such as cognitive deficits, seizures, paralysis, et cetera, in those that recover is very high. And one of the diseases that complications, neurologic complications that is of interest is subacute sclerosing panencephalitis, or SSPE, on this slide. Again, not a common complication, but an indication that this virus can cause persistent infection and late complications of infection. So this is a fatal neurologic disease, but it doesn't appear clinically until 7 to 10 years after the original virus infection. So understanding how we actually recover from measles is one of the questions that our laboratory has been particularly interested in. Now, sometimes it's thought that, well, all these complications and deaths, et cetera, are only occurring elsewhere, in Africa, et cetera. And it's true, the mortality rates are much higher in developing countries, primarily because of access to medical treatment for those secondary infections that occur. But this is a compilation of complications that are occurring in the United States. The white bars are hospitalizations, and this is different ages, and so you can see the youngest individuals and the oldest individuals are most likely to develop complications that require hospitalization. In addition, diarrhea and pneumonia and deaths do occur in the US and Europe, et cetera, as well as in developing countries. The only intervention that we have for measles once you develop this disease is vitamin A, and we have to mention that because it's been an important contribution of Al Sommer here at Johns Hopkins, but it was noticed the orange bars are mortality in the absence of vitamin A, and the yellow bars are what the mortality is if you supplement children with vitamin A. So vitamin A, and these are 3 different types of studies, have been shown to definitely decrease the mortality. But other than that, we have no interventions other than antibiotics for these secondary bacterial infections that may occur. So one of the questions in our lab has been understanding the reasons for complication and how you establish long-term immunity. And so how well is the virus cleared, and how does the immune response that's generated during infection lead to lifelong immunity? This is a goal for many vaccine programs, and if we could understand it better for the natural disease, perhaps that would help us to be able to apply that to what we know about vaccines. Well, one of the things our studies have shown is that there's a lot of virus. That's the blue shaded thing, is the amount of virus that's circulating in the blood during infection. And then the appearance of the rash, the red bar, is associated with clearance of that virus and recovery. The fever goes away, et cetera. But there's a very long period of time during which that actually is required for the virus to be cleared completely. So we can continue to find viral RNA in respiratory secretions, blood, urine, et cetera, for very long periods of time, months after infection, and may help us to understand some of the consequences of the later consequences of viral measles virus infection, and perhaps why immune suppression is a major issue, and also perhaps these late manifestations like SSPE, where virus has never actually been cleared from those individuals. So in summary, measles is a highly infectious human rash disease that causes a substantial morbidity and mortality. And the only interventions that we have are vitamin A and antibiotics. And it's a serious disease in developed countries as well as developing countries. And the virus has cleared slowly, and so some of the late complications of measles, we don't completely understand how that happens. But there is the immune suppression and susceptibility to other infections. These late neurologic complications like SSPE, the induction of autoimmune diseases like the encephalomyelitis, but then also development of lifelong immunity after recovery. So thank you. Right. Okay.
There is time for one moderator question. Your questions I'll ask during the panel. The slide you showed with being able to find viral RNA for weeks out. When a child or anyone has measles, the current recommendation is 4 days after the rash they can go about their business. Why are they no longer contagious?
Right, so we can't recover infectious virus. So if we try to culture the virus, we can't do that for, 4 days out is a good time frame. But we know the virus is continuing to produce proteins, is continuing to stimulate the immune response during this period of time. But there's no evidence that those individuals are infectious for other individuals after the rash is cleared.
Thanks very much. So get your questions for Dr. Griffin, and we'll address those in a little bit. Our next speaker is Dr. Jane Seward, who is the Deputy Director in the Division of Viral Diseases in the National Center for Immunizations and Respiratory Diseases at the CDC. She's worked on measles outbreaks in the U.S. around the world. She's one of world leaders in the control of measles. And she's going to be giving us a talk this morning on measles in 2015, a situational update. Dr. Seward.
Good morning, and thanks for inviting me here today. So just to follow on from Dr. Griffin, measles caused a lot of disease burden in the United States before we had the vaccine. And so we estimate that essentially everybody got measles before they were 10 years old. There were 3 to 4 million estimated cases a year. of which about 500,000 were reported. So if you look at the old slides of reported data, that doesn't indicate the health burden. Everybody got measles. Those cases resulted in about 50,000 or 48,000 hospitalizations, 4,000 encephalitis cases, as you just heard, a very severe complication, and 450 to 500 deaths every year, and most of those were in healthy children. Global burden of measles, you'll be hearing a little bit about that later or in the panel discussion. In 1980, when the expanded program on immunizations started around the world, there were an estimated 2.6 million deaths occurring by then. And over the last 13 years, there's been a huge effort globally to try to improve measles control, and there's been a 75% decrease in estimated deaths over this time period, so tremendous achievements. Nevertheless, as you heard in the introduction, we still have about 146,000 deaths a year, or 400 deaths a day from measles around the world. So it does remain a leading cause of vaccine-preventable deaths in children less than 5. Lots of complications, and some of them include blindness in the developing world. Around the world, and this is very, very relevant to the US experience, there's a lot of measles still. We estimate 20 million cases. And the world's very interconnected, and so a measles case, if you travel, you might come in contact with one, there's a fair chance, and you could bring it back here. So despite, again, tremendous achievements in global measles control, with a 72% decrease in measles over the last 13 years, there's still a lot in the world. This slide shows, this is a WHO slide showing measles case distribution by month in different WHO regions. And those regions are the African region, the Southeast Asian region, the American region, which region of the Americas, which you can't even see because there are so few cases, the Eastern Mediterranean, European in red, and the Western Pacific in brown. And I'll point out here, because I'm going to be coming back to these points when I talk about our importations, there was a lot of measles in Europe in 2008 to 11. And that's the red. I mean, the African region numbers dwarf it, but there's not so much travel to and from Africa. There's a lot of travel from the US to Europe. So we had a lot of measles importations from Europe between 2008 to 11. And then over the last year, you see the huge increase in measles in the Western Pacific. There was a very large outbreak in the Philippines that is still ongoing, actually, although it's decreased. And then there was also an outbreak in Vietnam and a number of other countries in the region. And then we got a lot of importations from those places. Just to highlight France, what happened in France between 2008 to 11. If you look at 2008, they actually had pretty low numbers of measles. And in the years before that, very low number of reported measles. And then they had a huge outbreak over a few years of more than 20,000 cases, and there were 10 deaths. So as Dr. Griffin, you just heard, measles can kill. It can kill in developed countries. There's no antiviral medication to treat. It's still a very serious disease. I'm going to briefly review vaccine recommendations and coverage to set the stage. You'll hear some more about this from some of the other presenters. So measles, measles vaccine, the monovalent vaccine's no longer available in the United States, but it was licensed as a single vaccine in 1963. The combination MMR vaccine was licensed in 1971, and that's the only vaccine we have now, or that and MMRV, that was licensed in 2005 or 6. And so you cannot get the single measles vaccine or rubella or mumps anymore. Excellent safety profile, and Dr. Halsey is going to talk about this in more detail, so I won't dwell on this except to point out that local injection site reactions are by far the most common problem after the vaccine. Vaccine's highly effective, and Dr. Halsey is going to talk about that. So these are our U.S. MMR vaccine routine recommendations from the Advisory Committee on Immunization Practices from the American Academy of Pediatrics and Family Practice. Children and adolescents should get 2 doses at 12 to 15 months and 4 to 6 years, but you can give the second dose at least 28 days after the first dose. And then if you get a child coming into your office at 5 and they've had no doses, then you need to catch them up and give them 2 doses. So anytime you see a child who hasn't had 2 doses, they should be offered vaccine. So that's the catch-up. Adults without evidence of immunity, and that means adults who are born after 1956, birth before 1957 is essentially everybody of that age has had measles and are considered immune. So that's one of the evidences of immunity. The other is a blood test showing that you have serologic evidence. And the third, though very uncommon, evidence of immunity is confirmation of having had measles disease. And some people might have that from the resurgence or from recent years. So adults who lack those things need 2 doses of measles vaccine, MMR vaccine, for healthcare workers, post-high school students, and travelers. Other adults just need 1 dose, and a lot of people don't realize that. They think it's a 2-dose recommendation for all adults. It is not. And then we just highlight the travel recommendations because we see a lot of measles in travelers. It's people that go overseas and bring measles back that aren't covered or haven't had that early dose for an infant 6 to 11 months. So this is a special travel recommendation that children, infants 6 to 11 months should receive 1 dose before they go anywhere overseas. And then people 12 months and up. The first recommended age is 12 to 15. We see a fair amount of measles cases in that age group because they haven't had their dose before they went. They intended to get it, but they're not 15 months yet, and their doctor didn't talk to them about the importance of being protected with 2 doses at that age group before they travel abroad. So we do put a lot of emphasis on these travel recommendations. And just a sort of a stage-setting slide on coverage, you're going to hear more about vaccine hesitancy and exemption from Dan Salmon. But our vaccine coverage levels in the US are for 1 dose among children at 19 to 35 months remains around 92%. And similarly, 2-dose coverage among our teenagers is similar. These coverage levels are okay, they're pretty good, but the 2-year-old coverage means that 1 in 12 1 in every 12 children is not vaccinated on time at 2. So if you turn them around, there is still quite a lot of susceptibility around the country. And additionally, these national level coverage or state level mask considerable differences in local communities. And I'm sure we'll be hearing about that in a lot more detail. So you saw this slide already from Dr. Griffin, but just to point out a little bit more detail, this is US reported cases of measles, dramatic decline after the vaccine was licensed and recommended. We did have some little blips in the 70s, and those were mainly measles outbreaks in schools. And then this resurgence in 1989 to 91, and that resurgence was due to failure to vaccinate in our inner city populations. We were spending a lot of our efforts and strategy on school requirements, and we were really ignoring children before they went to school. And so in some of our big cities, we had measles vaccine coverage that rivaled third world countries. And so that's where the outbreaks occurred in big cities, Chicago, New York, Los Angeles, Houston, et cetera. And we had many, many cases of measles and 123 deaths over that time period. Since then, we've had a lot of money put into vaccines at the federal level. We had the Vaccines for Children program, which was initiated solely to cover those children who didn't have health insurance or couldn't afford to pay, those children in the inner city areas that weren't getting vaccinated on time. And we've been tremendously successful in bringing our vaccine coverage levels up to the levels I just showed you. This is a slide on reported measles incidence, putting those reported numbers into incidence because the population changes over time. And you can see that even before elimination, we had gotten down below 1 case per million population and stayed there for quite some time. We declared elimination in the year 2000, but we've ticked up in 2014, as you'll see in my later slides. So we declared measles elimination in the United States in 2000 and achieved that due to high 2-dose vaccine coverage, high quality measles surveillance and response. This is a state function. The state health departments and local health departments do a wonderful job detecting and responding to a single measles case. And then improved control in the region of the Americas also made a lot of difference because we didn't have a lot of measles coming in from Mexico and other countries. But elimination doesn't mean it's gone forever. It means that there's no year-round endemic disease transmission in this country. So since before 2000, we have not had measles as an endemic disease transmitted year-round, but it comes in all the time from overseas and tests our population immunity, and we do get limited spread from some of those importations. So this was an infographic that CDC put out last year when we had a lot of measles importations occurring, just to remind everyone again that when measles happens anywhere in the world, it can come here on a plane very quickly, and it can travel here and spread. And so the best way to prevent that is to protect yourself before you travel abroad. So age-specific incidence is a very important concept. It's the number of cases of measles compared to the population in that age group. And so in the first 8 years after measles was eliminated, Amy Parker and my group at CDC did a nice summary of all the epidemiology and described here in this table in her paper age-specific incidence. And you can see that the highest incidence is in the age groups where the susceptibility is highest. The very highest in infants 6 to 11 months, and that's because infants less than 6 months still have some residual maternal antibody. They probably also don't get out and about quite as much as 6 to 11-month-olds, but their susceptibility is lower. And then the next highest was in the 12 to 15-month-old age group. And you can see that incidence was quite low and was very low in adults. So just remember that because I'm going to come back to that later. In the infant and 12 to 15-month-old age group, 12 out of the 58, so a third, and almost half of the 12 to 15-month-old cases were unvaccinated and traveled abroad. So again, just to reinforce the importance of those travel recommendations for protection, because a fair number of those babies, they're missed opportunities. Some of them are parents that choose not to vaccinate, but a lot of them are people that just don't know about the recommendations. And so pediatricians don't think somebody's going to Europe, do they need to talk to their patients about measles vaccine and an early dose, but they do. Here we see measles from 1996, the title's wrong here in the slide, to 2014, showing measles cases reported, and since 2001 we've been able to break the cases into importations of measles, shown in the red part of the bar, and other cases, mainly spread cases, shown in the yellow. And as you can see, and I'll show a bit more detail in the next few slides, in the early 2000s we had less than 100 cases a year, sometimes less, around 50, 40. And you can see the change in recent years, especially in the last 4 years. 4 out of the last 5 years, we've had the most measles cases reported since elimination, and really the most last year since even before 1996. And so the region of the Americas as a whole is documenting every country, country by country, under the leadership of PAHO, the Pan American Health Organization, is documenting and verifying elimination of measles. And since the United States had done this in 2000, we were asked to look again at our 10 years since elimination data and document that in a report and have it reviewed by experts. So we did that, and that report is available on the CDC website. And what that data showed was that we have a median of 60 cases a year in that first decade after, it's actually 11 years after elimination. And the lowest number of cases in a year was 37, and 220 was the highest number in 2011. We had 33 importations a year on average. Most of those are in US residents. A lot of people think it's those travelers from overseas that are bringing measles. Well, some of them do, but most of it is people from here going overseas and not being protected. On average, a quarter of our cases are hospitalized. We've had 2 deaths in 1,000 cases, so 1 death in 500 cases. The last deaths in the US were in 2003, although we have had some deaths due to subacute sclerosing panencephalitis since then. Our incidence remained, as you saw in the previous slide, less than 1 case per million. And the vaccination status, 65% were unvaccinated, 20% were unknown vaccination status. That's mainly adults, because we don't do a good job in this country of keeping our adult vaccine records. This is a plug for registries and trying to do that. It'll help us a lot, and 15% were vaccinated. On average, we had 4 outbreaks a year, and the outbreak sizes, the number of outbreaks a year ranged from 2 to 12, and the median size was 6. These are pretty small outbreaks. An outbreak definition is 3, so you have to have 3 cases before we call it an outbreak. The largest outbreak over that decade was 34 cases. And during that decade again, from importations, 84% of importations, there was no spread. So it's the minority of importations, at least in that decade, that spread. 9%, there was 1 import-linked case, and 7% resulted in 3 or more cases. And that's usually when a case comes back into a community of unvaccinated, like-minded people. That's when measles spreads. And the R0 in these analyses was less than 1, which is what you need to maintain for elimination. And you can see here in this figure that you can go and look up in this report that's cited at the bottom of the slide that, you know, most cases were 1. There were some two chains, meaning 2 cases linked, and then 3 and 4 is the green. So these are small outbreaks, 5 to 9 size outbreaks, and then bigger outbreaks. So now let's turn our attention to the more recent years. So this is, I'm including 2011 in both analyses. And so here we got 2011 to 14, the last 4 years, just showing that the reported numbers, much higher. 1 year was only 55, that was 2012. But 220, 55, 189, and then a provisional total of 644. That number could change, it's still provisional. So median mean in the 200s. That's a lot more than we saw in the decade of 2001 to 11. And so I've just listed the number of importations each year. You can see we've had a lot of importations. I mean, 2011, that was the year that we were just bombarded from Europe. Most of those importations, or the highest number, came from France. And we had 14 outbreaks that year. The largest outbreak had 21 cases, and that was in Minnesota in a Somali community who actually had a family that went to Kenya, back to Kenya for a family visit, and the 2-year-old came back with measles. In 2013, 54 importations, 11 outbreaks. The largest was 58 cases in New York City in a conservative Jewish population. And then 2014, 60 importations, 23 outbreaks, sorry, that's an error. 23 outbreaks, the largest 383 cases in Ohio in the Amish, which got a lot of news last year. This is a slide just showing measles genotypes. We encourage physicians when they see a suspected measles case to draw blood for serology, but to also get specimens for PCR testing, culture, and genotyping, because this can really help us link outbreaks and if we don't know the person traveled somewhere, and just confirm what genotypes are circulating where. And you can see that last year, the predominant genotype in the US was B3, and this was because of the Philippines outbreak. You see B3 is the only color there in the Philippines, also affecting Australia, Japan, China, almost all H1. China's having a lot of measles again after doing a lot of catch-up campaigns, but we haven't had many cases from there in recent years. So genotypes can be very helpful. This is just another different visual way of looking at measles cases, cumulative number by month, by date of rash onset, showing how extraordinarily different the last year was, and some of the most recent years, 2011, 13, et cetera, compared to the average number we saw right before and around elimination, or 2002 to 10. And what about this year? Well, it's not a great start. It's not a great start. That little dot, we've only got one data point, but it is way higher than anything we've seen to date. And actually, this is the highest number month to date since 1992. And so it is concerning. So measles in 2014, there's an error in this slide as well that I'll point out. Provisional total of 644 cases from 27 states. That's the correct number of states, and 23 outbreaks. 60 importations, I told you about that. 25 of those, almost half, were from the Philippines. The next highest number of 9 was from India. Every year, measles comes from India. We get 5 to 10 cases from India every year. 91% of those importations are in US residents. Last year, 12% of our cases were hospitalized. That's a lower number than we usually see, and that's because of the Amish outbreak. The outbreak in the Amish really drove those numbers because they didn't hospitalize as much. They took care of their children at home. So if we turn our attention, last year's numbers, to the cases in US residents, which was 635, 77% of those were unvaccinated, 15% had unknown vaccination status, and most of those are adults. The next number is incorrect. It should be 8% were vaccinated. And then if we look at the unvaccinated, and why were they unvaccinated? Well, some of them were too young. 8% were, less than 12 months and didn't travel abroad, so they couldn't have been vaccinated. 3% were travelers aged 6 months to 4 years who hadn't had their recommended vaccines. 79% were personal belief exemptors, people who chose not to vaccinate. And 10% were unknown. Most of those were related to an outbreak that occurred among people from the Federated States of Micronesia. This is age-specific incidence from last year, and it's very similar this year, year-to-date as well. Again, the highest incidence in infants and very low incidence in adults. There's a lot of cohorts in adults, 20 to 99, there's a lot of adults. And so even if you get majority of cases in adults, which is what we're seeing here this year actually, the incidence will remain very low because of the large number of adults. And so here's just a few more details about the exact sources of importations last year. You can see they can come from anywhere and everywhere, and they reflect where measles is occurring around the world and where US travelers travel to. So a lot more measles in Africa than we're seeing here, but there's not so much travel back and forth to Africa. So now going on to 2015, a lot of information and news recently about this. CDC will be releasing these numbers today. And I'm going to start with the outbreak numbers. It's a little confusing because this measles outbreak that started in Southern California linked to 2 Disney theme parks started on December 28th. And so our 2015 numbers, it crosses over years of reporting. And so it's made it quite challenging for the media and others to keep track of these numbers, and for people at CDC that we're briefing. So from 28th of February to 28th of December to the 6th of February, that's our cutoff date last Thursday, 114 people from 7 states were reported to have measles linked to, and should be completed there, at Disney theme parks in Southern California. So that's the size of the multi-state outbreak that is ongoing at this point. And also linked to that outbreak is a case in Mexico and 4 cases in Canada in people that attended one of these Disney parks. So there's been exportation from the US to some other countries now, neighboring countries. So this is 2015 measles cases in the US from January the 1st to February the 6th. And over this time period, we've had 121 cases from 17 states and Washington, D.C. So in addition, 103 of those are the outbreak cases. And so if you just do the math, 18 others are not, and those are our regular imports that are occurring at the same time. We've had an import from Azerbaijan into New York City and a spread case. We've had imports from different countries. I'll show you on the next slide. So those things are still occurring at the same time as we see measles in the multi-state outbreak. And so with the 11 cases that occurred in 2014 from the multi-state outbreak, 103 plus 11 gets you back up to the 114 for the outbreak. Some other highlights from 2015. Most cases are unvaccinated or have unknown vaccination status. We have 6 known importations from these countries that you can see here. Looks like Indonesia's showing up a couple of times already. India's already showing up, more likely to be India than Dubai, where they flew through, but can't be sure. There are adult and child cases. In fact, the majority of cases this year so far are in adults. But again, the incidence is low in that age group. We've isolated 3 measles genotypes so far. B3, definitely associated with the outbreak linked to the theme parks. And that's the genotype that was in the Philippines last year, but it was also in a lot of other countries in the region and has been in other states this year. And then D8 and D9 from different other parts of the world, Pakistan, Indonesia, etc., Azerbaijan, those ones. And then you've seen in the news, I'm sure, these recent cases in a child care center in Illinois. As of our cutoff date, 2 of those confirmed cases had been reported to CDC among babies under 12 months. Additionally, they had 3 clinically compatible cases that weren't yet confirmed, but they looked like measles, and some other exposed vulnerable infants. The investigation is ongoing by the state and local health department, and they're trying to investigate and discover the source. Clearly those babies don't walk around and they're all exposed right there. So somebody walked into the baby room highly infectious with measles 2 weeks before this date. And this reminds me of an outbreak we had in a child care center in Alabama over a decade ago, where a baby who traveled to the Philippines, aged 10 months, came back, got measles. There was a 100% attack rate in the baby room. 11 out of 11 other babies got measles. So just a quick slide on outbreaks in the US over the last 15 years, showing the largest ones. You can see there, I mentioned the Amish outbreak last year. Our outbreak now for this year is, again, these numbers it's difficult to keep track, but it's 103 this year and 11 last year for the Disneyland outbreak. And 58 in the Brooklyn outbreak. And you can see, 43 in 2014, another 25 outbreak in 2014, one in North Carolina in Hare Krishna populations from India who'd visited India in 2013, another one in Texas that came from Indonesia. So quite a few of these outbreaks are in recent years. And just one brief comment, measles is very expensive to respond to. It takes a huge amount of effort by local and state health departments to track down hundreds or even thousands of cases. And so we've done a number of studies to document the economic burden in the US. So in summary, measles in the post-elimination era in the United States is a disease that's due to failure to vaccinate. Measles elimination is a global problem. We're a very interconnected world, and so we can expect importations every year to keep coming in and testing our population immunity. Measles occurs in the US. The cases last year from the Amish came back to Ohio, went to their doctor and said, we've been in the Philippines and we're sick, and the doctor looked up dengue and travel illnesses and didn't think measles. And in fact, by the third case in the Amish, they said, I think I've got measles, and were told measles doesn't occur in the US anymore. So it's just, as Rich said, Dr. Besser said, no younger physicians have seen measles, and no young parents have seen measles, and so CDC tries to keep getting a lot of information out there and educational things to remind a doctor to think measles if they see someone with rash illness. Maintaining elimination is challenging and resource intensive. Maintaining vaccine coverage, we do see increasing vaccine exemption in local pockets around the country, and this is where outbreaks occur. The case contact investigations are a huge amount of work. We need to maintain our healthcare workers' awareness and diagnostic skills. And then we have and want to use our advanced lab techniques to help link outbreaks, et cetera. A lot of people to acknowledge, and thank you very much.
Thanks very much, Dr. Stewart. One question for you, a question I get a lot. I mean, you were saying that the majority of people in this outbreak are actually adults. And what I'm hearing from a lot of adults, they want to know, they're absolutely clueless if they ever got a measles shot. They have no records from their childhood. What should they do? Should they get a blood test? Should they get a shot? What's the best way forward?
We tell them if you don't know whether you've had measles or not, go to your doctor, and the easiest thing is to just get a shot. If you get a test, you've got to come back. You may not come back. It may take a few days. So if your doctor doesn't have records documenting that you've got some evidence of immunity from a blood test or age-appropriate vaccination, just get vaccinated.
Great. Thanks very much. Just a reminder that there are going to be two panels. The first panel will be with this morning's speakers, and then following that will be a panel with local, state, city public health officials, as well as a leader from the American Red Cross. So be thinking of your questions for them so that we can pull those into those panel discussions. Our next speaker is Dr. Neil Halsey. He's director of the Institute for Vaccine Safety at Hopkins School of Public Health, which provides independent assessments of vaccines and vaccine safety. He's a pediatrician with subspecialty training in infectious diseases and epidemiology, a longstanding interest in the control of measles and poliomyelitis, has done a lot of work for the World Health Organization and domestic and international health agencies around vaccine-preventable diseases. And he's going to be talking about vaccine development and safety oversight. Please welcome Dr. Halsey.
Thank you very much, Rich. So I will mention that as part of my safety activities, I do serve on a safety monitoring board for studies of human papillomavirus vaccine, which is produced by Merck, the same manufacturer as measles. But measles has been with me throughout my entire career, even beginning as a medical student, watching children die from measles in Central America and then in North Dakota, and now in many other countries that we have been tracking this virus, and I never expected to see this number of cases in the United States. Well, the history of the vaccine goes back to 1954, when the virus was isolated by John Enders and Peebles here in the state of Maryland from a boy named David Edmonston, who was 8 years old at the time, who, when Sam Katz, one of the developers of the vaccine, went back and found him about 4 years ago, he was still working and still painting houses in Rockville, Maryland, has a big scrapbook full of all of the things that he's very proud of the role that this vaccine virus that came from him has played in the prevention of disease and mortality throughout the world. So they took this viral isolate and put it into cell cultures, passed it through various human cell lines, and then into chick embryo cells, which were easier to use for production of a vaccine, and through the serial passage attenuated or weakened the virus to cause a small and a light infection, but without all the complications that were associated with natural measles. And as you heard before, was first licensed in 1963. These are the history of the passages. That was the Edmondson B vaccine that was licensed, but because it did cause higher rates of fever and rash, further work was done, and 5 years later, the attenuated vaccines, now known, the strain in the United States is called Enders Edmondson, formerly known as Moreton strain, and in the package insert you'll see Attenuvax, which is the manufacturer's name for it. But it's very similar to the Schwartz strain, which is widely used throughout the world. There actually are 19 manufacturers of measles vaccines, and about 4 or 5 of them come from viruses that had different origins, but most of the work that is done throughout the world is from this original isolate, which was obtained now, 1954, that's 61 years ago, and it still works. It still protects against the disease that we have now, which is kind of remarkable, and we should ask Dan Griffin about that. I mean, the virus mutates, like all viruses mutate, but the vaccine still works against the strains that are out there throughout the world. So with natural measles, almost all children develop moderate or high fever and a rash, as you've seen some pictures of. With the Enders, the Edmondson B vaccine, they reduced that to a third to a half of the rates that you saw with the natural disease. With the further attenuated vaccine, when they gave the Edmondson B vaccine, it was given with a small amount of immune globulin, which that actually blocks some of the replication of the virus so that to reduce the rates of fever and rash to reasonable amounts. But with the further attenuated, you get that same reduction. You still see 10 to 15% will develop fever, and about 5% will develop a rash, but the rashes only last for a day or two, and the fever is short-limited as well. Nothing like what the natural disease is. That fever occurs in the second week after vaccination, 6 to 12 days after vaccination, we usually, with a peak between 7 and 10 days. With the MMR-V vaccine, when it was combined, when MMR and varicella were combined in 2005, it was noted that there was a slightly higher rate of fever with the first dose than, as shown in the black line, with the MMR alone. But there is no increase with combining with measles, mumps, and rubella together. Those are basically the same. With the second dose on the right-hand side, there's no increased rate of fever because almost all the children are immune, and that immunity blocks some of the replication of the virus so that you don't see an increased rate of fever. This increased rate of fever is associated with a small increase in the risk of febrile seizures in children because they're susceptible at that age, and that's MMR as shown in the pink line down at the bottom, giving it at the same time but separately with the varicella vaccine. You see it here. But with the combination of all of the viruses together, there is an increased rate of fever, so most pediatricians and CDC recommend that the first dose we do separate the MMR and the varicella vaccine. This is a source of some of the confusion that's out there about giving them all at the same time. But really with MMR, the adverse event rates are the same as with measles vaccine alone. So this increased risk is about 1 in 2,300 children. Interestingly, a lot of what's been in the news in the last few weeks has been people delaying immunization for their children because they're concerned about this very small, precious 12-month-old, that they want to wait a little while and make sure they're a little bit older and immune. recent studies have shown that actually delaying, even by a few months, is associated with a slightly higher rate of these febrile seizures. So it's not safer to delay, it's safest to give the vaccine on schedule. This is a self-controlled case series comparing the risk of febrile seizures in the 7 to 10 days after vaccination to other control times in the same children. There's about a 2.5-fold increased risk in that 7 to 10 days when given at 12 to 15 months of age, but it doubles at 16 to 18 months, and then 19 to 20 months, it's even a little bit more than that. Children are protected in the first few months of life from measles if their mother is immune, because the mother transmits the antibody across the placenta, so that the child is born with antibody and then does not get measles. And actually, back in 1990, at Rich Besser mentioned, we did see measles in 2 mothers and had intervened very quickly to give the passive antibody to the infants. One of the problems with the control of measles is the need to wait until that passive antibody has declined to levels low enough it doesn't interfere with the vaccine. Now, there have been more than 70 studies done that was put together by Bill Moss, who's on our faculty here, with Peter Strebel at CDC and WHO, summarizing the results of all these studies in different countries throughout the world. And this slide shows the medians and the box plots that are shown there. Note that the lower response rates in children less than 12 months of age. That's why we usually wait until 12 months of age to give that first dose of measles vaccine. In developing countries for many years, we had recommended it at 9 months of age because it was the best compromise, with a lot of measles occurring at younger ages. And as Jane Seward mentioned, for children who are going to be traveling to areas where there's measles or in the middle of a measles outbreak, we give an extra dose of measles vaccine to those between 6 and 11 months of age, in order that those that have lost enough maternal antibody that they're susceptible, they should respond to the vaccine. But that's an extra dose, so they end up getting 3 doses, 2 more doses after 12 months of age. So it's this delay until an older age that leaves some children susceptible, and if they defer the vaccine, they remain susceptible for a longer period of time. A single dose of measles vaccine given after 12 months of age induces a serologic response rate in about 96%, with some variability in different studies, and I forgot, it's about 40 studies that were summarized here. The post-licensure effectiveness is about 93% with variability in different studies and different communities, and these are all US studies. 2 doses takes you, in most studies, close to 100% protection, but there still are some that are left susceptible, small numbers of children. Of interest, if the first dose in some of those was given just at 12 months of age, or a little bit before, as has happened, then you see some of the lower overall protection from the 2 doses. So it's not perfect, but it's really an excellent vaccine. Some children can't receive that vaccine. Those who are immunocompromised from primary immune deficiency disorders, cancer chemotherapy, one of the most common reasons, or HIV infection that has not yet been brought under control and they're still severely immunocompromised. And we don't give live viral vaccines to pregnant women. So these children can't get the vaccine, but more and more now, they're out in the communities and attending our preschools and schools. And so we need to protect them. This diagram is from our National Institutes of Health, summarizing herd protection. Herd immunity is really a misnomer. They're not immune, they're just protected by everybody else being protected. So in the upper left-hand corner, if you introduce a highly infectious virus, like measles, as shown in the people in the red, then a large proportion of the population will become infected because of the high infectivity of this virus. The diagram to the right, if you can immunize the vast majority, almost all of the people, as shown in yellow, then when you introduce the virus by the person in red, there's either no transmission or very limited transmission. So they're protected. They're not immune. And they're susceptible for the next outbreak and the next outbreak, and then when they travel to Europe. So they're not protected for life. And that's the message that families need to get, that you're not saving them, even if people around you are protected. You're going to get measles at an older age, and you may have high complication rates, as we saw before. I think those children who can't be vaccinated should be protected through herd protection. Now, a number of our faculty have done studies with measles in other countries. Michael Koenig, who was a former member of our faculty prior to joining the faculty, did one of the instrumental studies in Bangladesh showing that measles vaccine protects against mortality. They introduced the vaccine in a step wedge design, sequentially, a few months delayed in different segments of the population here in urban Bangladesh, and then went back and looked at the cumulative mortality and noted that there was a substantial, a 45% reduction in mortality in the children who were vaccinated as compared to children in the same large community who had not yet been vaccinated. We did studies at the same time in Haiti, which showed a very similar effect. It was more protection than you would expect than just from prevention of measles. But these are not optimal study designs to answer that question. And there are a group out of Denmark, Peter Rabi, working in a number of different countries, has published many different studies arguing for an indirect effect or a nonspecific benefit of measles vaccine at protecting against mortality in developing countries. There are problems with most of those studies. They're observational studies and not definitive. More recently, their group, and working with other Danish investigators where they can capture all health outcomes and immunization in children in Denmark now, not in the developing country, have shown more suggestive data that there may be something to this. And I'm only showing one selected part of their publications here, but the children who had received 2 doses of DTP, I think it was, but had not yet received measles vaccine, when they were 16 to 24 months of age, had, it's a 15.1 per 100 person years rate of hospitalization for other infections, but the rate was significantly lower, 9.9 for the children who had received MMR prior to 16 months of age, suggesting the possibility that there may be something to this. The World Health Organization is actively investigating all of the potential indirect benefits beyond prevention of measles, so data are not convincing yet. There might be something to this. There are other side effects from measles vaccine. Frank Oski, working across the street in 1966, published a paper showing that when you give measles vaccine, within the next few days you get a drop in the platelet count in almost all children, shown by the children that they bled sequentially here. Measles virus infects a number of different cells throughout the body, but it also attaches to the circulating platelets. They're taken up and removed from circulation. That's why we see a drop in the platelet count. But, and that's due to a direct viral platelet interaction. But about 1 in 30,000 children, and they're slightly different rates in different countries, do develop later, 2 to 3 weeks later, an immune thrombocytopenia because the immune system has processed those platelets and put it in. And they can have some clinical bleeding, but it's transient and they recover from this. The biggest problem, of course, has been the false belief that MMR causes autism, promoted by Andrew Wakefield, a gastroenterologist who really went on a campaign to sell this false theory. The science behind this was known to be bad from the very beginning, at the time of the publication of the article, where he interviewed 12 families with autism spectrum disorder when the children were about 6 years of age and had some gastrointestinal symptoms. That's why they were sent to him. He asked the parents of these 12, did the onset of the autism come within 2 weeks after getting MMR? And 8 out of the 12 parents said yes. Now, anybody who knows any science knows that that's terrible science with leading questions and so forth. And he then went ahead and did invasive procedures and biopsied the intestine of the children and claimed to have found measles virus persisting in the intestine. Well, it turns out that not only does measles MMR not cause autism, as shown by more than 14 very good quality studies throughout the world, and the evidence is overwhelming to that, and the reviews that took place, even one I chaired in 2000 to 2001 for the Academy of Pediatrics, where we went through all the data and followed by the Institute of Medicine, and then the Vaccine Injury Compensation Program. Overwhelming, all the science for a long time has shown that there's nothing to this. It's false. The paper was retracted in 2010. It's a very good book about a lot of this, by Seth Mnookin called The Panic Virus. It's the best of a half a dozen books that are out there. And in 2010, Dr. Wakefield's medical license was withdrawn. The article was retracted. A large amount of credit to this belongs to an investigative reporter who we had speak here about this a few years ago. But he was able to actually go back and interview the families and found that the data were actually fraudulent that were there. It wasn't just bad science, they were actually fraudulent, and that Dr. Wakefield had been paid large sums of money, hundreds of thousands of dollars by attorneys to find evidence, and he had also started a couple of companies to try to make money off of all of that. So it's really tragic that this has gone on as long as it has, and people have had trouble accepting the science. There's still, as you've heard from some politicians in recent times, arguing, well, maybe it doesn't cause autism, but I know that it causes some other subtle neurologic problems and decline. Well, a group in Poland went back and looked at a cohort of children, and with the help of investigators from Columbia University, they had put 369 Polish children through longitudinal study with careful developmental assessments at multiple different ages that were shown here, out to 7 years of age, and compared children who had received MMR, and they had some unvaccinated, enough in Poland, and some who had received only the monovalent vaccine, and compared their test scores at all of these ages. And basically, they're almost identical. There's no difference between the two. One statistically significant difference at 36 months of age, the children who had received MMR were slightly better than the children who had received the monovalent vaccine. There's nothing to this false belief about MMR contributing to adverse neurologic development. Well, the World Health Organization estimates that today, if we had not had measles vaccine, we'd have about over 1.4 million deaths due to measles in the world, as shown at the top line of this diagram. The estimated number of deaths that are occurring now are shown in the black line at the bottom, and there are more than 1 million deaths prevented per year. Now, the motto of our school is saving lives millions at a time. Here's one single vaccine that prevents more than 1 million deaths every year. Thank you very much.
Thanks very much, Dr. Halsey. Our next speaker is Dr. Dan Salmon, who's the Deputy Director of the Institute for Vaccine Safety at Hopkins School of Public Health, Associate Professor in International Health and Health Behavior and Society. He's focused on post-licensure vaccine safety and the factors associated with parental decisions to vaccinate or not vaccinate their children. Before coming to Bloomberg, Dr. Salmon served as the Director of the Vaccine Safety in the National Vaccine Program Office at the Department of Health and Human Services, and he was responsible for coordinating federal vaccine safety activities. His talk is going to be on understanding the increasing rates of vaccine hesitancy and what we can do about that. Dr. Salmon.
Thank you, and thank you, Dr. Sharpstein and Dean Clegg, for the opportunity to talk today. I'm going to talk about what we know about vaccine hesitancy, which I think is a fair amount. And I'm going to talk a little bit about what we can do to address it, and that's where I think we really have more gaps. But to start by defining vaccine hesitancy, it's really a heterogeneous group of people. And the decisions they make, well, some of them refuse all or some vaccines, so they actively refuse. Some get vaccinated, but they delay when they get vaccines. And others will get all the vaccines, but they remain concerned. So these parents are still vaccine hesitant, and we'll talk more about them in just a second. Here we see immunization coverage in the U.S. over time among children 19 to 35 months. Dr. Seward showed the data for measles or MMR, and we see for the vaccines that have been around for some time, coverage right around 90%, which is really quite remarkable. So this speaks to the vast majority of parents vaccinating their children, which really is the social norm. At the same time, these are national data, and as we'll see in a few minutes, there is a fair amount of variability. Looking at recent data, this comes from a study by Allison Kennedy published in Health Affairs, and this is parents of children 1 to 6 years of age, and we see that 83% vaccinated or reported vaccinating with the recommended schedule, 11% planned to use the recommended schedule, 5% selectively vaccinated, so they got some vaccines but not others, and about 2% intended not to vaccinate at all. What I think is really remarkable from this study was 77% of parents reported concerns about vaccines, nearly 8 in 10 parents. Now remember, most of these parents vaccinated, many by the schedule, but they did so with concerns. And we see 8 out of 9 of these concerns, these were not mutually exclusive, so the numbers don't add up to 100, but 8 out of 9 relate to vaccine safety, either pain or too many shots at one visit or in the first 2 years of life. Remarkably, 30% are reporting that vaccines may cause learning disabilities such as autism, despite what Dr. Halsey showed as a fairly compelling science that that's not the case. So this is one of the points that I really want to make strongly today, that despite the fact that a lot of parents, most parents, 9 out of 10 are vaccinating, a lot of them are doing so with concerns, and concerns that I think can be addressed. There was a nice study done by Phil Smith using data from the National Immunization Survey, parents of children 19 to 35 months, and he looked at children that he defined as unvaccinated, or zero-dose kids. These are children that got no vaccines, and compared them to under-vaccinated children. And what he found was the zero-dose children, the ones that got no vaccine, were more likely to be white, belong to households with higher incomes, college-educated mothers, and living with 4 or more children. So this is really in stark contrast to the 89-91 measles resurgence, where there were pockets of unvaccinated children that tended to be lower income, immigrant populations. Here we see these parents that are refusing vaccines tend to be higher educated, higher income parents, and in fact, while the reason for lack of vaccination may be different, I think the virus itself is really looking for susceptibles regardless of reason. There was a recent study published by Tracy Liu in Pediatrics just a few weeks ago, and this was using Northern California or California Kaiser data, which is nice about this because it's a closed healthcare system, so they have really good data. And she looked at children that were under-immunized with this series by 24 months of age, what she defined as shot limiters. So these were children that were fully immunized by 36 months of age, but they never got more than 2 injections in a day. So the presumption here was these parents were trying to limit the number of shots that were given in one day. And we see that the proportion of children that fall in these categories increased over time. And this is concerning. They also had diagnostic codes for vaccine refusal, and they found that about 3.5% of parents in the most recent age period actively refused vaccines. Another way of looking at vaccine refusal is to look at exemptions to school immunization requirements. So when children are unimmunized as preschool children, there are many reasons why they may be unimmunized. Perhaps it's healthcare systems or access to vaccines or competing priorities, but by school entrance, every state has laws requiring vaccination for school entrance, and states have exemptions to those laws. All states allow medical exemptions. 48 states allow non-medical exemptions, all but West Virginia and Mississippi, and 19 states offer philosophical exemptions. And many people look at these different types of laws by religious versus philosophical. There's also tremendous variability in how these laws are implemented and enforced. And some states, like Maryland, have very easy exemptions. In fact, it's easier to get an exemption than it is to document vaccination of your child. And certainly easier than vaccinating your child. Other states have much more stringent requirements, requiring, for example, counseling with a healthcare provider, annual renewal, notarization, and other requirements making it more difficult to vaccinate. Here we look at the association between the type of exemptions and pertussis. And we find that states that offer personal belief exemptions and states that have easier exemptions have about 50% more pertussis compared to other states. So there's a clear correlation between the exemption policy at the state level and the incidence of pertussis. Here we're looking at the rates of exemptions over time. These are the state mean exemption rates. And first we see this overall exemption rates from 2006 to 2011. And we see that the rates of exemptions are increasing. Although I'll point out, and I'll get back to this, that the rates are overall still very low, right? It's about 2% of parents that are claiming an exemption. Looking at the religious versus philosophical type of exemptions, we see that philosophical exemptions, or states that offer philosophical exemptions, have higher rates of exemptions, but the rates are increasing among both states. Looking at states by the ease at administering exemptions, we see that states that have easy exemptions have more exemptions, and the rates of exemptions are increasing among states that have both easy as well as moderately difficult exemption procedures. Among states that have difficult exemption procedures, despite all these issues that we've been talking about, the rates of exemptions have really stayed quite constant over time. So as I mentioned earlier, the overall exemption rates, today are still pretty modest. They're about 2%, but this is at the national level, and this really hides the clustering of exemptions within states. Here we see the most recent school year Washington State School District exemption rates, and I draw your attention to the red and the dark red, where 10 to 20 or more than 20% of kids have an exemption. So the exemption rate in Washington State is about 6%. So that's higher than average. But frankly, if you live in a school district where 1 in 4 kids or 1 in 5 children aren't vaccinated, the state exemption rate or the national exemption rate doesn't really help you much. So vaccine refusal, kind of like politics, is really a local issue. What matters to a parent and the risk to a child is what is the likelihood of your child coming into contact with an unvaccinated child. So there's been a number of studies that have looked at the increased risk of disease for children that have exemptions. And we found that, for example, children that were exempt were 22 to 35 times more likely to get measles, more likely to get pertussis, Hib, varicella, pneumococcal. And this makes sense, right? Because we know that vaccines work, not perfectly, but very well. And if I don't vaccinate my child, then my child is at greater risk of disease. This is the primary reason we vaccinate. But my child may place your child at risk. Perhaps your child is too young to be vaccinated, as we've talked about with measles. Perhaps your child can't be vaccinated for medical reasons, or perhaps your child has been vaccinated but hasn't had a sufficient immunological response, right? Because no vaccine is 100% effective. And here we saw a study that was done by Saad Omer. This was actually his dissertation here. And he looked at this clustering of exemptions. This is in Michigan. And in yellow are the clusters of exemptions, and in red is the clusters of pertussis. And what he found was that if you lived in an exemption cluster, you were about 3 times as likely to live in a pertussis cluster. And this really gets at the community risk of exemptions and part of what's going on now with measles. Another study that was done by one of our doctoral students, Jessica Atwell, looked at the clustering of exemptions here in blue and then the clustering of pertussis in red. And this is in California, and we've seen an increase in pertussis in California and many states, which has largely been attributed to waning immunity. And the data there, I think, is very compelling that a lot of what's going on is waning immunity. Jessica's study showed that, in fact, vaccine refusal was also probably contributing to the issue as well. So why are parents claiming exemptions? And we did a case control study looking at parents that had exemptions compared to vaccinated children. This was in 4 states. The children were matched by school, by grade, and we found that parents of children that had exemptions were more likely to report low levels of disease susceptibility and severity, low levels of vaccine efficacy and safety, less trust in healthcare providers, and less trust in government. So this is really a combination of factors playing together. We were interested in then understanding what role healthcare providers play in this, because we know that even among parents that don't vaccinate, they often get information from their providers. And we surveyed the providers of these children at ages 2 and 5 to 6. We found that the providers of exempt children were more likely to be doctors of osteopathic medicine and complementary alternative medicine, such as chiropractors and naturopaths. This is an area where I think we can really make some progress and understand better. We found that the exempt providers were less likely to report that children in the community benefits from vaccines and more likely to have vaccine safety concerns. There was an interesting study recently published by Michelle Mergler, another one of our doctoral students, that found that parent and provider vaccine attitudes were highly correlated. So, for example, when a parent had a concern about the number of vaccines given at once, that provider was also more likely to have that concern, which is interesting, and it suggests that perhaps providers are impacting the decisions of parents. But we have to be careful with that, because it may not be a causal relationship. We know that about 25% providers refuse to care for patients, and Dr. Roeder will talk more about that, but it may be that a parent is coming into a doctor's office and sharing their concerns about vaccines, and the provider doesn't want to care for the patient. And as a result, the parent finds a provider that shares or is more likely to share their attitudes and beliefs about vaccines. And in this case, there'd be a correlation like we found, but it's not actually the doctor who's causing the parental beliefs. So one question which has been asked for some time among clinicians, and it's caught a lot of media attention, is should physicians refuse to care for unvaccinated children, presuming that they should be vaccinated? And many clinicians have expressed concerns about the child's welfare, which is clearly the primary goal of the pediatrician, and acknowledging that that child isn't vaccinated at the increased risk of disease. There's also concerns about the welfare of children in the practice, because unvaccinated children are more likely to transmit disease, and that could pose a problem in a practice setting. There's also issues of liability if the child develops a vaccine-preventable disease. And importantly, the large amount of time that's needed for repeated counseling with these parents. If you look at vaccine delivery, while it's widely embraced by pediatricians, it's not a great financial deal for them. If you look at, for example, the reimbursement for administering a vaccine, it might be $10 or $12. That has to cover ordering, handling, refrigeration, investments in inventory, keeping track of what vaccines is given in the immunization records, and then, of course, administering the vaccine. As soon as a parent asks a question about vaccine safety, this is a loss leader for clinicians, and this is problematic. There was a statement by the American Academy of Pediatrics that says pediatricians should generally not discharge patients for vaccine refusal. They point out that some parents do change their minds, and they want to minimize seeking care from alternative providers, as I mentioned earlier. So there's an interesting study that was published from Doug Opal's group at the University of Washington, and they've done some great work in this area. And they observed the conversations between clinicians and parents, and they oversampled vaccine-hesitant parents. And they found that the majority of providers, about 74%, took a presumptive format. Well, we have some shots to do today. So the presumption was, we're going to vaccinate. A smaller percentage took a participatory format where they asked the parent, what do you want to do about shots? And this approach was more common among vaccine-hesitant parents, and there was higher resistance to following recommendations when this participatory format was used. Interestingly, a lot of providers stuck with their original recommendation, and in the end, about half of parents ultimately accepted the recommendation and got a vaccine at that visit. So this is suggestive that this persistence to the recommendations may in fact get more children vaccinated. There's a fascinating discussion among the authors in the discussion section of this paper, and they asked the question, well, what is our goal in health communication? Is it informed decision making, which is what most health communication aims to do? Or, on the other hand, given the clear benefits of vaccines and that it's a standard of care, should our goal be simply compliance with standard of care? And I think that's a challenging issue and one that we need to address better. They also acknowledged that they didn't look at the long-term impact on these parents. So while it's possible that more parents got vaccinated by focusing on compliance, they weren't able to study the long-term impact on the parent-provider relationship. We recently conducted a systematic review of evidence to decrease parental vaccine hesitancy, and we found 30 studies in these different categories. We applied the WHO grade criteria to the quality of these studies, and I think this really highlights a problem we face today, was that we didn't find any convincing evidence of effective interventions to address parent vaccine hesitancy and refusal. So there's lots of people that have ideas, and we found lots of commentaries on what one should do. We found lots of studies where people reported what they did and self-reported that it worked. But when we looked for the rigor and to determine whether or not they had the desired impact, whether that be informed decision-making or vaccine uptake, we found very few studies that had any compelling data, and there weren't clear strategies based on science that worked. This study was completed in 2013, so the studies that were included were through 2012. And there was a really interesting study that I'm going to highlight just briefly that was published in Pediatrics, and this was a randomized trial of almost 1,800 parents testing 4 interventions. So the first intervention, or the first group, was a control group that had no intervention. The second group was corrective information. So this was information produced by CDC looking at a lack of evidence that MMR causes vaccines. MMR causes autism. So if a parent has concerns about this, perhaps providing the science will change it. The next intervention was information, again, from CDC, talking about the dangers of diseases prevented by MMR. And this stems from the belief that parents don't know what these diseases look like, and therefore they're not worried about them. And if they understand the risks, which you folks saw today, you saw the data on, that this might change their mind. The next intervention was a narrative, which was a dramatic narrative about an infant who almost died from measles, again coming from CDC, and again emphasizing that if parents understood the risks of these diseases, that might change their beliefs. And lastly was a picture of a child with MMR disease. So the thinking is that a picture, shows 1,000 words, and if again they understood the risks of disease, they might think differently. So here we see the proportion of parents who report vaccines cause autism by the different group of the study, and we see that the corrective information reduced the proportion of parents who reported vaccines cause autism. I'm going to get back to this in a minute. It looks like good news, but it might not be that good. It also found that the images increase the proportion of parents who report vaccines cause autism. So in this case, showing this image actually backfired and had the opposite result. But going back to a minute for this corrective information, which reduced the proportion of parents who reported vaccines cause autism, it also asked about intention to give MMR vaccine among those parents that were least favorable towards vaccines. And what it found was that the corrective information reduced the likelihood of a parent intending to give MMR vaccine. So while it may have gotten them off of the issue of autism, in the end, it didn't have the desired impact. More parents at least reported the intention of not vaccinating their children. When looking at the proportion of parents who report MMR side effects, again, the narrative had the opposite effect as what one would hope. So it may be that trying to scare parents into vaccinating may not work. And in the end, in vaccines, we need really high compliance. We need 95% of parents to vaccinate. So it may not be that these compelling narratives and stories and pictures actually have the desired effect. So let me just change focus a little bit about what we can do about this, because I've tried to characterize what we know. And just a few thoughts on my own here. As I've said, we don't have a lot of evidence that we would like to base interventions on. But I think one opportunity lies in pregnant women. During pregnancy is what we refer to as the teachable moment. And that's really an opportunity to start teaching women and their families about vaccines. And given we recommend vaccination during pregnancy, maternal immunization seems like a good time. I think it's also important that we think about the healthcare providers and the whole systems approach, the healthcare setting, and it's important that we individually tailor information because we know that different parents come to this, different people with different issues, and taking a one-size-fits-all approach probably isn't going to work. We were recently funded by NIH to develop and evaluate a patient, provider, and practice-level intervention, and in time we hope that this will show some promise. So just my closing thoughts on what to do about vaccine hesitancy. We've seen in some states the restrictions of the laws for exemptions. Washington, California, Oregon, and Vermont are states that have historically had high rates of exemptions. They've had a lot of pertussis, they've had easy exemptions, and they've recently passed legislation to make it more restrictive. And we've received funding from the Robert Wood Johnson Foundation to understand the implementation and impact of these changes, and this might be a way forward. We've heard recent calls to get rid of non-medical exemptions altogether, and the media has pointed to West Virginia and Mississippi and pointed out, well, if there's no non-medical exemptions, then almost everyone is vaccinated by school entry. In fact, Washington State recently had a piece of proposed legislation that would get rid of their philosophical exemption, and it's been supported by the Department of Health. I think we have to be careful here because by forcing every parent to be vaccinated, we may in fact cause a lot of backlash. And these exemptions serve as a relief valve and an important policy approach so that there's less pushback from parents. I think there's more we can do to enhance our safety science. As you've seen the data, measles vaccines and vaccines broadly that are routinely used in the US are extremely effective. And we have a very robust system for monitoring safety. But there are scientific opportunities. We have large healthcare systems that have databases that can be combined, such that FDA is doing with PRISM and Mini-Sentinel. And this affords the opportunity to look at very rare epidemiological relationships, to look at subpopulations. There's advances in immunology and genomics, so we can understand the biological mechanisms by which vaccines very, very rarely cause adverse events and perhaps preclude those children from being vaccinated. I think we can be more responsive to parental concerns and do more science. We recently looked at independent review and found that to be helpful. I think we need more tools for providers, more strategies, and importantly, we need strategies that have been shown to work. We need solid evidence to know what works and what doesn't work. So on there, thank you.
Thanks very much. A lot to reflect on in our panel discussion. Our next speaker will continue on a similar theme, talking about reflections on patient-centered discussions about childhood vaccines. This will be given by Dr. Deborah Roeder. She's the University Distinguished Service Professor in the Department of Health, Behavior, and Society here at the Bloomberg School. Her primary research focus is patient-provider communication. Her research includes clinical investigation of patient and physician interventions to improve the quality of communication and enhance its positive effects on patient health outcomes. Dr. Roeder.
Hi, thanks for inviting me. I appreciate the opportunity to add my voice to what's been said about hesitancy in discussing hard conversations, difficult conversations with parents. I'm going to preface my remarks by noting that, as my colleagues have said, that regulations requiring the strict enforcement of whatever vaccine restrictions and exemptions that exist are an important public health foundation. The reality, however, is that regulatory policies vary by state by state, and in places in which the exemptions are liberal, difficult conversations occur with greater frequency, particularly with vaccine-hesitant parents. And those conversations are the ones that often are reported to be problematic. So what do vaccine-hesitant parents really want? They want to talk about vaccine safety. They want their physicians to hear what their concerns are, answer their questions, help them understand help them understand why their doctor is recommending what they're recommending and why. But that's not all that they want. They want to feel that their concerns are taken seriously, that they are treated with respect, and they want to feel that they can trust their doctor, and more than anything, they want to be sure that what they do is the right thing for their child, that they're acting in their child's best interest, that they're acting as a responsible and good parent. So what does the American Academy of Pediatrics recommend a pediatrician do? The primary recommendation is to be patient-centered. And Dan talked a bit about those recommendations. My read of those recommendations is that there are three things that a pediatrician is guided to do. The first is be patient-centered, and by that I mean address the needs and wants that the patients have expressed, and as I talked about in the previous slide. Primarily among those needs and wants is to listen respectfully to the concerns that they have, answer their questions, and educate them not by lecturing to them, but by explaining and clearly stating what their positions are and why they have these positions. The second recommendation and perspective is to think about the end game. And what that means is that the relationships occur and evolve over time. I think that the notion that there is a difficult conversation around vaccines may be amended to acknowledge that these can be difficult conversations, that they occur repeatedly, and that the relationship is one that is committed to the same overall goal of protecting a child's well-being. It also suggests that there may be some flexibility, and you heard from Dan's slides that many parents request, and clinicians fairly often will accommodate spreading out the vaccine schedules. I think that it's important that that aspect is incorporated into this idea of the end game. How can we work together to ultimately achieve our mutual goal, which is to have these children be as healthy and thrive as well as they can? Finally, what the Academy says is avoid firing or dismissing your patients. Work at a relationship, but when you feel, and perhaps in those cases it's mutual, there's a distrust that develops, and there are philosophic differences that emerge regarding the role of the patient and the provider in this relationship, and I'll talk a little bit about that toward the end of my talk, that communication is not building and contributing to a more productive and strong relationship, that you might have to consider dismissing a patient, or a patient might decide to go elsewhere. So you have a sense of what patients want. You have a sense what the Academy of Pediatricians suggests. What do pediatricians think of these conversations? Well, they're difficult. It takes time. And I think Dan had noted this, that for conversations with patients who have significant concerns. Now, I think it's interesting and important to note that 3/4 of parents have some concerns about vaccine safety. A smaller proportion have very serious concerns. Nevertheless, it takes time to discuss these concerns. For those who have significant reservations regarding the safety of vaccines, the report by Kemp and others show that 4% of these pediatric encounters take less than 4 minutes, 36% take between 5 and 9 minutes, but over half, 53%, take 10 to 19 minutes, and greater than, and 8% take greater than 20 minutes. That has to be seen within the context that the average pediatric visit is about 12 minutes. So it provides this setup for frustration, and as Dan was saying, it could potentially raise issues regarding the curtailing of anticipatory guidance regarding other preventive issues. So we have to acknowledge that that parents who have significant concerns, addressing those concerns take time. Just as a matter of contrast, we know that discussions with most patients, or patients without significant concerns, is significantly less time consuming. So for them, only 9% of the encounters are over 10 minutes, and we know that most, 50% is less than 4 minutes, and another 42% is that 5 to 9 minute segment. So it's a significant investment in time. We also know that it's not easy. These are difficult conversations, and it's associated with physicians' report of lessened job satisfaction. About 1/3 of the physicians in the Kemp study reported that their discussions with parents that have serious concerns of vaccines lowered their job satisfaction. 6% suggested that it very much lowered their job satisfaction. We know that the issue of physician burnout is an important and increasing confrontation to our medical, manpower. And I think we need to consider this coupled with the time constraints and the time demands that having these conversations have. The third element is that it sometimes ruptures relationships. So in the Kemp study, it was reported that up to 23% of pediatricians said that they would dismiss patients who refused vaccines in some manner. There was another study of the American Academy of Pediatricians membership that found that 40% of members thought that they would or have dismissed families who refused all vaccines, and 28% dismissed those refusing at least some vaccines. Another context is that it sometimes takes flexibility, and as was recommended by the Academy, some 13% of pediatricians had reported that they often or always spread out vaccines in terms of their schedule, and another 50% reported that they sometimes do that. So what do pediatricians say works with their parents? Well, the primary three things that they say is important is a strong personal statement regarding what they do. Patients overall and parents want self-disclosure in regard to practices. It's the most authentic report of beliefs. Have you vaccinated your own children, or would you vaccinate your own children? They also want to know what the physician's experience has been in their practice with with vaccine safety, with other parents, and what is their experience overall in terms of vaccine preventable disease. So there are a number of things that can be done, but the obstacle and a primary barrier is time. There's a duty to persuade in the cases of childhood vaccines. As Dan had said, almost half of resistant parents in the OPAL study agreed to vaccinate if the physician continues the discussion after initial refusal. The key and important element there is that a clinician recommendation is the most important factor parents note as having changed their mind. So the recommendations have to be clear. They have to address in a balanced way, acknowledge the risks and benefits of both immunization and non-immunization. But they have to be done in a way that confers and extends this notion of sharing both the clinician's experience and eliciting what the patients think and know. So can we think about a best framework for vaccine discussions? I think we know that patient-centeredness is important, and patient-centeredness is included within this notion of mutuality, the sharing of perspectives, expertise, and experience, mutual respect, positive regard, and trust. That is what collaborative partnerships are about. Other models exist, and when conflicts erupt, they probably reflect an underlying tension between models of consumerism, where patient perspectives and expectations may predominate, and the physician is regarded as a technical consultant, one for whom their expertise is not truly invited, or paternalism, in which the physician perspective, the medical perspective, buoyed by expertise and beneficence, trying to do the best thing for the patient, predominates with dismissal of patient concerns as wrong or naive, or, of course, even worse in this very hot context. So what can we say about this area? What is the conclusions? For physicians, be patient-centered and forge a collaborative partnership, but be clear about what you know and what you recommend, and be clear to the patient to present the rationale for why you believe your recommendation is the best thing to get them to their mutual goal, which is a healthy baby and healthy community. Listen and consider what patients worry about, what they value, what they question, and what they understand. And for parents, like patients in general, I think it's important that they continue to be an active partner in decision-making. And what that partnership entails is being open to discussing what your concerns, values, questions, and understanding is with the physician, but also by hearing and listening to what your clinician thinks and why. And we should be reassured that the clinicians, the patient-parent relationship is valued as the most credible, significant, and meaningful relationship regarding the well-being of their child that parents report. So, thank you.
Thanks very much. In a moment, we're going to be taking a very short break, but I want to remind you that the next two sessions are panel discussions. You should have received cards, and if you send them down the aisle and down to the front, I'll look at those as I'm leading the next two discussions. The first panel will be with the speakers we've just heard. The second panel will be with public health officers. For those of you who are watching online, email your questions to jhsph.events@jhu.edu. And although you were expecting a 15-minute break, because we've gone a little long, we're going to try and hold it to a 5-minute break. So good luck out there, and we'll be back here in about 5 minutes. So a wide range of questions have come in. If you have questions as this is going on, please bring them up, as well as questions for the next panel, which will be with health officials. All right, this first question, Neil, maybe I'll throw your way. What, if anything, should be done about the very small but often vocal minority of physicians who are anti-vaccine, especially those who maintain designations such as Fellow of the American Academy of Pediatrics, yet do not follow or vocally oppose the recommendations of the AAP about immunization, which is such a central tenet of pediatrics?
That's an excellent question, because I personally have encountered some of those individuals, and there are a few, fortunately very few in our state, but there's one particular one in Virginia. And I believe that the society, the professional societies and the overseeing organizations that oversee physicians' boards in every state should do more. And recommending against routine immunizations, I think, is a form of extremely poor practice and borders on, if not, being malpractice, because it's not in the best interest of the child. The boards have always, the societies and the overseeing boards have always recognized the rights of physicians to practice with some variance from the guidance that's out there, because there is some art to the medicine, and as we heard with discussions with physicians, that there are parents who sometimes need to do some things in a little bit different way, but recommending against giving vaccines and sometimes promoting alternative medicines that they are in fact selling, I think is very bad practice and inconsistent with good practice of medicine. And I think more can be done. In fact, to a limited extent, some things are being done, and because individuals who do that also are not following good science in other areas, and some of them have been punished, and there are rare instances where licenses have been revoked, but not primarily for this reason.
Thanks. Does anyone else want to comment on that? The next question, I'll throw this to you, Dan. would you recommend mandatory measles vaccination, banning all personal exemptions?
So I made mention of this in my presentation. I think we have to be really careful. My concern, I mean, we can see in states like West Virginia and Mississippi that do not offer non-medical exemptions, that if you don't offer them, people don't take them, right? So it's intuitive, or it's tempting to say, well, let's solve the problem by getting rid of them. My concern is the potential backlash that that creates. I think in states and places where a lot of people really have concerns about vaccinating and they don't believe it's in their child's best interest, albeit their read of the science may be wrong and their position is not supported by evidence, if a parent really believes that it's not in the best interest of the child and they have no option, they're left with either doing something that they think may harm their child, moving out of the state, or homeschooling their child. And I think those are very difficult decisions to put a parent in. So I think that with the perhaps exception of a really, really bad outbreak, I think the solution is not to become, to take away the option altogether. With that said, I think there could be a time and a place where there's such a high risk because of a disease outbreak that a state could use its legal authority through its police powers to compel vaccination, and in certain circumstances maybe needs to do so.
Could you just add to that, and maybe you would comment more, Dan, because you have in other settings. The ease of which parents get exemptions is something that we can do some things about. And just when you take your child to register for school and sign a little form saying, I don't want them to get vaccinated, should not be sufficient. There should be a more rigorous requirement with regard to those deeply held personal beliefs. And there is a difference, as you showed in the slides, that the easier it is to get an exemption, the higher the exemption rate. So do you believe we should have more strict laws in most states that would require it to be fully educated, informed, and documentation of what the parents went through, so that it isn't just the easiest out for them?
Yeah, no, I absolutely think that that's an approach that more states need to consider. I mean, some of these requirements, for an example, annual renewal provides an important approach because people's beliefs may change over time, the science may change over time, and requiring the parent to revisit the issue on an annual basis makes sure that those issues get addressed. Things like requiring educational counseling. If you have a parent walking into a school saying, I'm decided not to vaccinate my child, that's certainly an opportunity to address the parent's concerns. There was a nice article written by Saad Omer in the New York Times last week, which really discussed this issue well, and our group has spent some time studying the impact of different approaches to implementing and enforcing exemptions, and I think making them more stringent may in fact help get rid of some of those parents from claiming exemptions that really don't have strongly held beliefs.
Deborah, this for you. We saw some of the data that Dan presented about trust and how that plays a role in some of these decisions. Has there been an erosion in trust in the medical community that we're seeing here, or has that kind of been a baseline thing? What we were hearing from Dan is that you really can't answer this just by giving people more science, though that's how most of the people, most of us were trained, and that's what we respond to. How do you work on that trust factor?
Well, I think that trust is central to the doctor-patient relationship. I don't think that it's declining, but I think that taking this notion that that trust is independent of other attributes of the relationship is not right. I think that parents who feel that their pediatricians or their physicians are respectful of their concerns and their questions, that they are concerned and committed to the overall well-being of their child, elicits trust. So I think trust occurs alongside of respect, engagement, attention to what kinds of concerns and questions the parent has. So I don't think that there's been a decline in trust, although some people will say that lots of the contention, the conflicts that we see are from parents who really value a consumerist and autonomy approach versus clinicians who don't feel they can or are willing to invest the time to really address these concerns. And that conflict is what then leads to an erosion of trust and this capacity to go to the end game, working together.
Jane, some vaccine hesitant parents prefer to separate MMR into individual vaccines. As you were saying, that's no longer an option here. Two-part question: is it safer to administer vaccines separately? Should this be available here in the United States as a way of addressing some concerns that parents have?
It's not safer to administer them separately, and if you delay, as we've discussed, you might be exposed to the other disease and acquire it. There was a measles outbreak in San Diego about a decade ago, and one of the children, there were 4 children infected in a doctor's office. 3 were babies under 12 months, but 1 was a child who delayed and was waiting to get the single measles antigen. That vaccine wasn't available, and it's not available now. It's safe to go ahead and give MMR vaccine, and I don't think the manufacturer has any plans to break it up again.
Diane, this for you. When an adult gets measles, are there more complications than with kids? Is it more dangerous?
Actually, yes. The incidence of hospitalization is higher in adults than it is in sort of school-age children. I don't know that we really understand the reason for that, but the facts are that actually it can be a more severe disease in adults than it is in somewhat younger children. The very youngest children have the highest mortality, but the sort of the typical age we used to all get measles was at school entry, sort of age 5 or 6 is probably one of the times of the least complications. But
Neil?
I can just add to that. I mean, I have some slides with other vaccines showing that, in fact, the immune response to some vaccines is slightly lower as you increase in age, beginning at around age 13, so that we're the healthiest from an immunological standpoint at that school age and younger than they are. And we see increased rates of other complications from infectious diseases other than measles in adults than we do from children. So it's all consistent. Our immune system is actually declining slightly as soon as you get your driver's license.
Jane, this one for you. Back during the period when the Wakefield paper came out and there was a lot of concerns raised about vaccines and autism, in particular around the preservatives, the thimerosal in the vaccines. One of the responses from the medical public health community was to remove that from vaccines, to address those concerns. Did that strategy backfire in a sense of giving some credibility to concerns that science did not support?
Well, firstly, just to clarify, thimerosal was never an MMR vaccine, as you know, but it was in a number of other vaccines. I think the American Academy of Pediatrics and the U.S. Public Health Service, in retrospect, think that there was no evidence at the time. They went ahead and made what they thought was the safest recommendation at the time to remove thimerosal from pediatric vaccines, even though there was no evidence it caused a problem. I think for the general public, that sent a message that there must be something that's unsafe, and so I think that there was concern raised by that decision.
Neil?
Yeah, I take a little bit different stance since I also played a role in helping push for such a policy. And it's not time or the right place here to talk about that, but I think had we not done that, I think we would have lost more credibility. We would have an even bigger problem than we do now with the acceptance of vaccines. It was the right thing to do. It was a painful thing to do, and it was misunderstanding on the part of family. But had that not been done, it would have been a hard sell for a number of the other vaccines that were given to very small infants at a very early age. So strongly believe it was the right thing to do and would do it again.
Diane, for you, we were just saying that measles is more dangerous if you get it as an adult. Some in the vaccine hesitancy community attempt to have their children, quote, naturally infected rather than vaccinated, i.e. exposed to chickenpox, et cetera. Good idea?
Well, no. And I would just elaborate a little bit on the adult issue. In the encephalomyelitis that I talked about actually is very uncommon in young children, and it is much more common as you get older. And so one of the most important complications and long-term complications of measles is more likely as you, certainly in older children as well as adults. I mean, we have these vaccines because the diseases themselves are dangerous and have complications and have mortality associated with them. And so the idea that getting the disease is better than being vaccinated doesn't have much credibility.
The next question has to do with, no, I think I'll skip that one, excuse me. New measles vaccines. Are new measles vaccines needed? Are they being developed? Would there be benefit from a new vaccine?
Okay, this is mine. The vaccine we have is excellent. And people have been, including us, working on new approaches to measles vaccination, mostly with the goal of trying to lower the age of immunization. Because right now, because you have a live virus vaccine, maternal antibody interferes with the replication of that vaccine and so prevents you from being able to immunize children, usually before the age of 12 months. So you can immunize earlier, but 12 to 15 months is an optimum age, and it's in large part because of this presence of maternal antibody. So there is research ongoing to that end. Probably what's more likely to occur, because I don't think there's a lot of pressure or even interest in trying to develop a new measles vaccine because we have a safe, good vaccine, is the possibility of giving the vaccine by a different route. Right now it's given subcutaneously, and there is a moderate amount of research and active clinical trials ongoing to look at the possibility of giving it as an aerosol, which would, certainly in developing countries, would decrease the need for needles and syringes for trained medical personnel, a number of things that are barriers to high coverage with measles vaccines. So those studies are being conducted in India, and we'll see what happens.
Jane, we know from the live polio vaccine that at times that can cause infection in other people. The measles vaccine is a live vaccine. Does it pose risk to other people?
No, it doesn't transmit easily at all.
Does it ever transmit or revert to wild type in the way that
No, it never. There's never been any reversion to wild type. And although I don't know every bit of the safety literature, I don't think there's ever been a secondary transmission. There has been with varicella vaccine. Neil, do you?
No, that's absolutely correct. This was actively investigated actually a long time ago when I was at CDC in the mid to late 1970s. And there is no evidence of any transmission of the measles virus from a child who is susceptible who got the vaccine to their household contacts and otherwise. So that's pretty good evidence that there is no transmission and no risk to contacts.
Jane, a question that I've gotten a lot. If the measles vaccine is so good, how come a lot of the people who've gotten measles in the outbreak are vaccinated?
Yes, this is a very difficult concept to explain without getting out a drawing board and actually putting the numbers, which is often what I do to make the point. This is a very effective vaccine, but as all of us have said here today, it's not 100% effective. And so you are going to get some cases in vaccinated people if vaccinated people are exposed. We do have very high vaccine coverage rates in this country, and so most of the people exposed are going to be vaccinated. So if you have 1,000 people, 900 of them are vaccinated, and all exposed, the whole 1,000 are exposed, 900 are vaccinated, if there's a 3% failure rate, you're going to get 27 vaccinated cases. And in the 100 of unvaccinated people exposed with a 90% attack rate, you're going to get 90 cases. And so about a third of the cases overall in that 1,000 will be vaccinated despite a highly effective vaccine. And so it's a function of the fact that most of our population are vaccinated.
This last question will come to you, Dan and Deborah. In hearing your presentations, I was getting more and more depressed about the ability to have an impact on my patients who may be vaccine resistant, but a little less depressed about those who may be hesitant. What one piece of advice would you give to a clinician out there who is concerned about this and wants to improve their vaccine coverage rate in their practice? What should they do?
I would say that think about the end game and the long run, and that these are difficult conversations that occur over time. Kids come back quite often, and that the issue of vaccines should be revisited. I think that as that relationship evolves, it strengthens, and the position that you might have 6 months ago with a patient may change, and the patient will be more, more interested and willing to take recommendations and considerations.
Okay.
So I wish that I had evidence to show you what works best, and we're working on that. I'm not a clinician. I don't give recommendations to parents, but I've had many occasions where parents have contacted me, and typically one parent's worried about vaccinating, and the other parent's worried that the other parent's worried about vaccinating, and they find me. And I have a conversation with them where the concerned parents ask their questions, and I tell them what the science says. I don't try to convince them to do anything, but I summarize what the evidence tells us. And inevitably, the conversation ends up where one of the parents asks me if I have children and what I've done with those children. And my response is I have 6 children who are all fully vaccinated. And I think that in addition to hearing the science, that gives them a sign of comfort that they're making the right decision.
Well, I want to thank all of our panelists for a hearty discussion. We're going to switch out the 2 panels. If you have questions for our next panelists who are all involved in the field application of public health, please write those on cards and send them over. We'll swap out and start right up with the next panel in just a moment. Well, terrific. I want to introduce our next set of panelists. I've just met them, so hopefully I will get this all right down the line. Starting here on the end is Luke Greaves. He's the Executive Director, International Services for the American Red Cross. Sitting next to Luke Greaves is Dr. Lena Wen, who's the Health Officer of the City of Baltimore. Next to her is Josh Sharfstein, you met earlier, here at the School of Public Health. Dr. Laura Herrera is the Deputy Secretary for Public Health at the Maryland Department of Health and Mental Hygiene. And next to her is Dr. Gregory Branch, who's the Health Officer of Baltimore County and President of the Maryland Association of County Health Officers. And they all, in their own way, have been thinking about measles, about this outbreak. They've had to respond to measles and prepare for that here. I'm going to come to you last, Luke, to get the international perspective that you have so well. And start with you, Lena. And I'd like you each just to say in brief a little bit about what are you doing to prepare for measles? How concerned are you about measles in the community that you're responsible for?
Good morning, everyone. So I want to actually start by telling you a story, and it's a story that some of you in this room will know. I started my job about 3 weeks ago, and in week 1, we had a case of suspected measles here in Baltimore City. This was a case of a 12-month-old girl who did not have any travel history, no known exposures, no ill contacts, who had fever followed by characteristic rash, so characteristic that she was diagnosed on site when she was seen in the emergency department, actually here at Johns Hopkins. And we began investigations, as we would with any other case of possible measles. We found out that this child actually had, she had received the MMR vaccine about 2.5 weeks prior to her rash starting, but again, had no ill context. And we thought most likely this was a vaccine reaction. However, we could not be certain, and especially with the outbreak going on around the country. And as we talked about, given how contagious measles is, we decided that even if we thought this could be a false alarm, that we would act out of an abundance of caution and treat this as if it were suspected measles. And so in the Baltimore City Health Department, our epidemiologists, our doctors, many of whom are in the room actually right now, got together, did contact tracing. This child was actually seen in another hospital prior to her ultimate diagnosis during her potentially infectious period. And so we worked closely with DHMH, with the CDC, to trace down every person who could have come into contact with this child, whether it was in the hospital setting, in the family setting, and so forth. And luckily, it turned out, based on the genotyping that was obtained at the CDC, that this child, in fact, did not have wild-type measles, that this patient ended up having a vaccine reaction, which, as we heard from Dr. Griffin this morning, does happen in up to 5% of cases of patients who do receive the MMR vaccine. We're very fortunate that that's the case, but to us, here in Baltimore City, this was a wake-up call. We are fortunate, too, that in the city we have a 99% vaccination rate for our public school children. Yet it's still a reminder to us that Baltimore is not an island, that this could really happen to any of us anywhere, and that we're fortunate to have the collaboration with our state and federal officials and in our city health department with our multiple hospital partners who have been wonderful collaborators in this process.
Thank you very much. Let's talk to one of your state partners, Dr. Herrera.
So in Maryland, we only have exemption for religious and medical reasons, and for medical reasons, you do have to provide documentation. For religious reasons, you do not, and that's based on a case from 1982, and the state made a decision that we wouldn't ask for that. We have seen practically patients start their immunization schedule, and then patients filing that religious exemption and then starting or stopping those immunizations, but that's only 0.1% when we look across all 24 jurisdictions in the state of Maryland. As Dr. Wen said, for kindergarten through grade 12, our immunization rates run between 97 and 99%. We don't have an exemption for philosophical reasons. The measles case has certainly caused us to not only look at our own regulations, but certainly the authorities of the secretary. If there were an outbreak, what could we do? One of which is the religious exemption. We could say you have to get vaccinated, and if the parent chose not to vaccinate their child, then they would be exempt from school. They would not be allowed to attend school. The other thing we're pausing to look at as well is we have not done a good job in capturing immunization schedule for preschool. So from 12 months to before you start kindergarten, we don't get the reports the way we do from school-age children. So now with the new leadership, at least at the State Health Department, and the relationship that we built with MSD, we are going back to start trying to get those immunization records from preschool children where we haven't historically. We don't have those numbers the way we do for K through 12, and only about 50% of all our primary care providers, pediatrician, family medicine, report in our state immunization registry.
Gregory, at the Baltimore County level and across the counties preparing for this?
We clearly are extraordinarily concerned about the measles and the spread of the measles. So we look at it from a perspective of let's cease the measles. Or you can't hear me. Let's cease. Hear me better now? Cease the measles, C-E-A-S-E. So we can do consultation with our hospitals. We do consultation with our daycare providers with the schools 24 hours a day. So if anyone has any questions, they can call the local health departments and we can discuss that. We have to educate and we have to train the public and our staff as it relates to any type of measles or measles outbreak. We administer the vaccine to our children in our health clinics, also in our school wellness-based clinics. We do surveillance, we do monitoring all the time, and obviously we have to evaluate and investigate any potential cases of measles. So we look at it from a perspective globally in the local health departments as trying to cease the spread of measles.
Josh, you worked both at the state level and at the federal level. I mean, I'm hearing vaccine coverage rates in Maryland so high. Maryland doesn't need to worry about this?
You know, when I was actually the city health commissioner, there was a big effort to try to roll back some vaccination coverage in Maryland. There were bills in the General Assembly, there were hearings where people were presenting a lot of misinformation. I think that it's really only because of the tremendous efforts of people like Dr. Nguyen, Dr. Herrera, Dr. Branch, that Maryland is in this position, and I don't think we should take it for granted. I was even in a situation where some witnesses were so totally mischaracterizing the very clear reports of the Institute of Medicine that I had to get the president of the Institute of Medicine to write a letter to the state Senate to clarify the record. So, you know, we're really, I think Maryland is a state that has very strong public health, very strong public health leaders, has built a base of trust with people in Maryland that has been able to weather some of the storms. But I think Dr. Nguyen said it right, that it's not an island. That it's constantly going to require the leadership to be thinking about what more it can do as measles is spreading around the country.
Luke, I want to pull you into the conversation. You've worked around the globe trying to increase vaccine coverage rates. What can we learn from that experience that has applicability to what we're seeing in the U.S. right now?
Sure, thank you. It was about 15 years ago where the Red Cross got together. About 15 years ago, the Red Cross got together with CDC, UN agencies, and local health officers from around the world to address measles. We have this effective vaccine. We know that it works, and it just wasn't getting to the communities. Over the last 15 years, we pulled together our resources. We've helped vaccinate 1.8 billion, with a B, children around the world, and have seen measles deaths decline by about 75%. And really the success of this has been organizing national and regional mass vaccination efforts. Over the course of days, over the course of 2 weeks, we get out into the communities and mobilize the parents to bring their children to the vaccination posts. And we see 90 to 100% coverage rates as part of those campaigns. And there really are three things that are really critical towards this, to driving up the demand. The first is removing those barriers, removing the barriers to getting the vaccine. Instead of having the mothers have to travel to the health clinics, the district health clinics to get the vaccine, we're bringing the vaccine to the mothers. We're bringing it to the schools. We're bringing it to the places of worship. We're bringing it in Africa underneath the big tree in the village. Where the parents are, where the children are, is where we're bringing it. We're also making the vaccine free of charge, of course, to the families. The second is that we're taking the message beyond just the health professionals. The health professionals do a great job in educating and providing credibility to this, but we also have volunteers who are going door to door and sharing their stories, engaging in that conversation that we heard of earlier about the importance of vaccination. We're engaging social media. We're using community leaders, religious leaders, local celebrities to get the word out. And we know that this peer-to-peer, this localization of the message works. In many cases, it actually increases the coverage rate by 10 to 15%. And as we heard earlier, that is critical with measles, where you need to have this 90-95% coverage rate. And then the final is we've added incentives to providing supplemental health interventions when we provide the measles vaccination. In Africa, we're handing out malaria bed nets. We're giving out polio vaccinations. We have this double benefit of not only addressing additional health issues, but it also serves as an incentive for the parents to bring their children in. And when you're reaching 90 to 100% of every mother, every child in a country. It's an amazing distribution network that we have to take advantage of.
A question I want to ask to a couple of you. When I see the presentation of vaccine safety often in the media, it's often science versus a mother and her child and their personal experience. Lynn, I'll start with you. How do you avoid, or how do you deal with the incredible strength of an anecdote, of someone's experience, when you're trying to make a case about vaccine safety and why someone should vaccinate their child?
It's hard. So much of what we do in public health is hard. And so much of it is you don't hear the good things that we do, right? You hear the news about public health when outbreaks happen, when there are diseases, when there are bad consequences. And public health often isn't about what are the things that we can do to improve health, but actually that's what we do every day in surveillance and teaching and so forth. You know, I'm a practicing doctor as well, and I've had these very difficult conversations with patients where no matter what science we present, that power of the story, the power of the anecdote is what overrides at the end of the day. But you know what, we can do the other way around too. We can also present anecdotes. One of the reasons, I think, as to why our parents now are not vaccinating their children as much as before is that we haven't seen, our generation of doctors, our generation of parents, we haven't seen the scourge of measles. We haven't seen the ill effects of polio. We haven't seen, we've become so successful at vaccination and at public health that we haven't seen what happens when people die, when there's fear and uncertainty and illness and tragedy that's happening in our communities the way that our predecessors did. And so bringing these stories back, not as a scare tactic, but to explain, for example, the numbers, even the stories that we heard earlier from many of our panelists, the millions of cases of measles that occurred, the hundreds of deaths that occurred every year. Having those stories also helps to counter the perception of a celebrity or someone who says that, well, measles vaccines or some other vaccines are not safe for some reason. And I do think that it's the genuine conversations that are helpful. I encourage my patients to ask me anything. And it's that trusting relationship that has to be developed. So the questions themselves are not bad, but we have to be able to counter the anecdotes with our own stories that are powerful as well.
Josh, a question for you, putting on your old FDA hat. Mm-hmm. Vaccines, when they're licensed, they're tested in thousands of children, maybe tens of thousands of children. Then they're administered to millions of children. What is the FDA doing to ensure that very rare side effects or ill effects of vaccine are detected?
Sure.
Just tying into the whole people's confidence in the vaccine safety.
Absolutely. No, that's a great question. Before I turn to that, I just wanted to add one quick thing to what Dr. Wen said, which is I think it's a bit of a gift to public health that this latest outbreak happened at Disneyland, because I think it helps with the conversation with parents. It is a story that can be told to parents that Disneyland became unsafe because people didn't vaccinate their children. And I think it's a different way it's a way of actually crystallizing the benefit to the community of vaccination. To your point, there are different components of the vaccine safety system, and I certainly have found that the people who are working on vaccine safety care very deeply about making sure that they're getting it right. There's a lot of analysis that's done on the large trials that are done prior to licensure. And then there are systems for catching adverse events, even rare adverse events, and assessing whether they may be linked to the vaccine or not. And when they are linked to the vaccine, even if it's a couple in a million cases, that gets assessed very seriously. If you look at what happened with a particular vaccine against a diarrheal disease called rotavirus, that vaccine was actually withdrawn from the market just for a very small increase that scientists and the FDA found to be a real increase in the rate of an intestinal blockage. And so you see both reporting of events, but also systematic studies where they're looking for rare events that could be happening. I think Dr. Salmon talked about the fact that there are new data sets that happen in large healthcare organizations that are being looked at for problems. There are a lot of people, very, very smart people, whose job it is to comb through all the evidence, evaluate every potential problem that's come up, assess whether it's real, and then take action. And having worked directly with those people, it gave me even more confidence in the way that vaccines are regulated.
This next question for you, Laura. Maryland, you were saying, only has a religious exemption.
And a medical exemption.
I'm sorry, only has a medical and religious
Correct.
exemption. How do you avoid a situation where people's personal beliefs, in a sense, become their religion, and that category starts to capture that group?
So we haven't seen an increase in the religious exemption. It's been pretty steady going back a couple of years at 0.1 to 0, 0 to 0.1 across all jurisdictions. I think to the points that were made already, it's, we continue to work with the delivery system and working with the pediatricians and the family medicine and other providers that are educating their patients about why immunizations are important. The health department pushes out information, not only through the different medical academies, the Maryland chapter of Academy of Pediatrics and family physicians, but we push out information with MSDE out through the schools to parents and to the leaders of schools about why immunizations are important. So that information continues to be put out, and based on that, we have not seen an uptick if individuals who maybe philosophically don't agree with the immunizations now using this religious exemption. So, and I think that's just that all the players at the local level, the local health departments, our federal partners pushing out information that has worked for us in Maryland.
If the measles outbreak came to Maryland and got large, what emergency powers do you have to compel vaccination? And would you ever do that?
So yes, we would do that. For the medical, we would ask providers to look at those individuals, whether it was a permanent medical exemption or a temporary medical exemption. And for the temporary medical exemption, if those individuals had not been vaccinated, to see if the window for them to be vaccinated has passed, get those children vaccinated. And for the religious exemption, the emergency powers trumps the religious exemption. So we would mandate that all children that fall in that category be exempted. And if they wouldn't, if the parents refuse, we can exempt them from school and have them quarantined for up to 21 days.
Thanks. Gregory, question for you. Some parents who are vaccinating their children raise the question, yeah, you're keeping these children out of school, but what about the parks? What about the mall? What about other places where children congregate? How do you ensure that vaccinated individuals are safe in those settings?
Well, obviously, if someone is not vaccinated, we cannot ensure that. We try our best to be able to decrease the amount of communication and communicable diseases within certain settings and environments. However, we're not going to have a person not be able to kind of go outside or tell a child they can't go to a park. But every child who is not vaccinated really has the increased risk of being able to come down with that wild disease. And obviously there are a lot of complications to that. So we have to continue to address the families by understanding and talking with them about what their concerns are, but continue to push the underlying point of vaccinations are imperative and very important and will save their child's life.
Lena, in some states, a parent can go online and look up to see what the vaccine coverage rates are in their child's school. Is that something available here in Baltimore?
To look it up online or
yeah.
to...
California, you can plug in your school name. I was having fun with this, finding schools with 50, 60, 70% of kids not vaccinated against measles.
Well, the good news in Baltimore City is that our vaccination rates in public schools are over 99%. And that's one of the reasons why we have not had any case of measles here, at least in over 10 years. So I don't know that we can look it up by school, but the overall vaccination rates are so high. And we also provide, as Dr. Branch was saying too, our efforts include not only surveillance, but also providing vaccines to all of our children who are underinsured or uninsured, again, to ensure, to allow them to protect themselves and also to protect our wider community.
Laura, this question for you. Are exemption rates measured in Maryland in private as well as public schools?
They are both. We get K through 12 reporting of both. And you can get it at the county level, just not at the school district level.
Have you seen any evidence of clustering of low vaccination in school, even within your 99%?
No, we went back a few years, given the recent rule-out case in Baltimore City, looking at the medical and religious exemptions, and both have been fairly stable for the last few years when we looked by jurisdiction.
Luke, for you, one of the issues that we've been hearing about here in the United States is no one sees measles, and so the demand side for vaccine goes down. People aren't worried about diseases they've never seen. Your experience in Africa, how much was that people didn't want the vaccine versus couldn't get something that they really, really wanted?
Right. I mean, it's a bit of a mix. I mean, there's definitely the access issue. There's definitely the access issue in much of Africa and Asia. India right now has the highest measles rates in the world. And part of this was also fears. While it wasn't autism, the fear is of other local cultural issues. I remember being in Kenya last year where we were administering some measles vaccinations, and the community was very fearful that if you injected one of their children, they would be possessed, the demons would come out through them. So we have to address this at a community by community level, but they very much are present around the world. And what we're seeing is in Africa, where we've had such great gains over the last 15 years, the same thing that we have in the United States is people haven't seen measles in their community in so long. We have a new generation of parents that are there, and they opt not to go and get their child vaccinated. So we're seeing a resurgence of measles in many parts of the world.
Josh, again, putting on a federal kind of hat here, no state exists in a vacuum. You can kind of think of Maryland as that vaccinated school and child in the classroom, maybe surrounded by kids who've decided not to vaccinate. A lot of people who live in Maryland work in other states, and you have people here who may be immunocompromised. They're impacted by people in other states who don't vaccinate. Should vaccination be something that's at the state level to determine, or should it be something determined at the federal level in terms of requirements?
I think, generally speaking, it should be at the state level. I think that's where there is the best chance of getting a policy that is strongly supported in the different local areas. I do think, though, that in the case of a serious outbreak, I think the federal government's responsibility is to protect the health and safety of the people of the country. And I think, I'm sure at CDC, there are plans for what could happen if measles really explodes. I think that it may get to a point where there are so many cases that the federal government needs to step in, like it does in other situations, like it could do in the case, as we were talking previously about Ebola, there'd be a scenario for the federal government stepping in. I think that is partly the federal government's responsibility to be a safety net around public health.
I think we are just about out of time. If anyone had a last comment, otherwise we'll take the few minutes to switch off for our last speaker.
Let me just say, to your point about looking up the school vaccination rate online, I'm not sure what I think about that. I think I'd like it, I think Dr. Wen said if you looked it up in Baltimore, you'd see 99% for every school. The implication is, well, just go, if you don't like vaccines, go find a school that does where nobody vaccinates, I think, and I think the point here, it's beyond transparency. It's beyond just, let's just see what people want to do or their own choice, that there's just such a huge risk to health, to having that kind of concentration of non-vaccinating that I would probably prefer a stronger public health effort around vaccination than kind of an internet-based transparency solution.
So you don't feel parents should know whether the school they're sending their child to has a low vaccination rate?
I think that the focus should be on not having schools with low vaccination rates. And I think that there's a potential counterproductive aspect of a system like that. So I'm just saying that, it's not about so much what the parents should know, but where public policy efforts should be addressing measles. It really has got to be focused on making sure there aren't schools where you could have an outbreak where the kids who have HIV, have cancer, and or just by a roll of the dice get one of these horrible complications that we heard about.
Thank you all very much. moving on to our next session, which I'm very much looking forward to. We're going to be hearing from former Representative Henry Waxman. Congressman Henry Waxman is one of the most influential and prolific health lawmakers ever to serve in the House of Representatives, sponsored key legislation on a range of health and environmental issues during his 4 decades in Congress. When Representative Waxman announced his retirement in January of 2004, President Obama described the congressman as one of the most accomplished legislators of his or any era. Among his many accomplishments, Waxman was deeply involved in public health policy on vaccine research, funding, and distribution. He authored the National Childhood Vaccine Injury Act of 1986, which established a vaccine adverse event reporting system and created a no-fault compensation system for vaccine-related issues. We've been seeing a lot in the press lately with politicians weighing in on their perspective around measles vaccination. Please welcome Representative Waxman on the politics of vaccines.
Thank you very much, Dr. Besser, and I appreciate this chance to join this forum today, and I compliment the Johns Hopkins School of Public Health, the Bloomberg School of Public Health, for hosting this event. This is a teachable moment for this country when we see a disease that was almost completely eliminated in the early 1980s now come back with a jolt all around this country. We have to ask ourselves, what is going on? Why are we experiencing this serious problem? Vaccinations are the most effective public health interventions in the world. They save millions of lives each year. This is a revolution in public health when we have had vaccines developed that can prevent terrible, serious, often deadly illnesses. Vaccines can make you immune to smallpox, immune to polio, and immune to measles. But no vaccine can make you immune to politics. Not even vaccines are immune to politics. And that's what I want to discuss, because during my 40 years in Congress, I've seen politics threaten vaccination efforts time and time again. The threats have been in several categories. One, whether we were going to have budget policies and oversight policies that would be keeping faith with science. And every time an ideology propped up to threaten the immunization programs in this nation, what we had, fortunately, was enough reasonable people, Democrats and Republicans, who were able to put the needs of our children and their health above ideology and partisanship. Now, we've been hearing today, in the last few weeks, reports about the politicization of this issue. And people point to comments made by Senator Rand Paul or Governor Christie, comments that I think are irresponsible. And I think they realize now we're irresponsible when they talked about getting immunized as a matter of personal choice. Senator Paul is a libertarian. He thinks this is a personal matter. But the point of the vaccine is not just to protect your own child, and therefore maybe you can decide whether you want your child protected, but it's to protect the public. It's to protect other children. It's a matter of not just personal responsibility, but civic responsibility to make sure that contagious diseases are not spread. When you have a matter that threatens the public, government has an essential role to play. This is not a partisan issue. I know a lot of people think perhaps it's partisan because they look at Republicans taking the role of denying science when it comes to climate change and evolution and other basic scientific facts. Some Republicans have a problem dealing with a consensus of scientific evidence when some of their constituents who are conservative, because of their distrust of government or their feeling that maybe science is just as valid as any other personal opinion, look at it from a perspective that we need to accept the fact that science is based on examining evidence. It's not a personal opinion that's being expressed. It's opinion based on evaluation of the evidence, which lead to rejection or acceptance of different hypotheses. But this is not a partisan matter, and there has been broad bipartisan support for immunizations. And I want to point out previous occasions where politics has come up over the question of immunizations. For most part, the issues at the federal level have been to remove barriers to getting a vaccine. So in the 1980s, President Reagan proposed cutting the vaccine program. The federal vaccine program was to give money to the states for public health purposes, and money that was to be used for immunizations, and he proposed a cut in the 317 program because he was looking at it as part of his overall budget. Well, we had held hearings on this issue and the consequences that it could lead to, and we heard from doctors who were warning us at that time about measles outbreaks and other outbreaks of diseases that were completely preventable. Congress wound up rejecting these proposed budget cuts, and I was joined by my colleagues, Democrat and Republican, who worried about the impact of public health. So the vaccination cuts that were being proposed were rejected. But the funding was never as adequate as it needed to be. And the weakness of our funding system became evident to us in the early 1990s when we had another outbreak of measles, as we're seeing today. It was a horrible outbreak, and people realized that measles is very contagious and that measles could be prevented by immunizations. So we used that moment to try to say that we've got to assure that we have enough vaccines for people. But one of the problems we were facing at that time was that many of the drug companies were concerned about making vaccines and finding that it wasn't profitable to them because of the fear of product liability. And so we had dwindling numbers of manufacturers willing to make vaccines. Well, at one point, we only had one manufacturer making some of these vaccines. And when we have one manufacturer making a vaccine, the prices go up, shortages occur if there were any disruption in their manufacturing processes, and we were finding a great deal of fear that we wouldn't have enough supply of vaccines. Well, we looked at the problem and we said what we needed to do was to assure the vaccine manufacturers that these rare, very extremely rare cases where they might be held to liability could be dealt with in another way. We didn't want to say that people couldn't go to court. There are values in being able to go to court because our tort system makes the safety of products more secure. What we came up with was a no-fault system, an immunization, a program that would compensate those cases if they were related to vaccines without having to prove the relationship directly, but if some rare episodes occur with some vaccines, we would provide compensation to those who are injured. But we would still allow them to sue if they chose to. But for the most part, there was no choice to sue once the child and the family were going to be compensated. We had ideological problems. We had political problems. There was a fellow named John Bolton, who we often hear about in the context of foreign policy, but he was an assistant attorney general in the administration, and he said that we should oppose this vaccine compensation system. He said, one, well, it's not clear that there's any real federal reason to get involved. Secondly, he said that it's going to lead to more involvement of the Justice Department in compensation efforts. And lastly, he said this is going to create a new tax because the Vaccine Compensation Fund was going to be provided the funds necessary through a small tax on the sale of every vaccine. Well, that was his view, but it wasn't the view of the Department of Health. It wasn't the view of the President of the United States, George H.W. Bush, and we were able to get to the vaccine compensation system as a bipartisan matter. And it helped increase the number of manufacturers who are now available to make these vaccines. We got a compromise. Another issue that came up was when President Clinton came to office. And President Clinton said what we needed to do was to assure a supply that every child will be able to be immunized, and the federal government ought to take over that responsibility. Well, there were objections to that because, one, there are a lot of people who are getting the immunizations through the private system, and why should the federal government take over the whole business of vaccines? But we heard arguments such as, why should the federal government pay for immunizations if the parents can afford to pay for it? Well, that's an argument we hear often. But if you think about it in other contexts, it shows how wrong that evaluation is. We don't look to see whether a child comes from a home where the parents may be able to afford private education. If they are going to go to public schools, we say there ought to be public schools. It's a public matter. If people choose to have a private school education, that's their choice, but we need to provide public education for all children. The compromise that was reached on a bipartisan basis was to say, we'll let the private vaccine system continue on. People can get vaccines through their private insurance coverage. But for everybody else, for all children, we would guarantee that immunization supplies would be available to them. It would be done through the Medicaid program. It would be done through the clinics. It would be done through the local supply system. And the U.S. government would provide complete 100% funding where there was going to be mandatory spending for vaccines administered through the community health centers, the public health departments, or Medicaid. Over time, governors, Democrats and Republicans, came to support a 100% federally funded vaccine financing program. So we had a compromise. We had politics. People raised problems, but we worked through them. But we had a worse problem in the Congress of the United States when Chairman Dan Burton, who chaired the Government Reform and Oversight Committee, decided to hold a series of hearings focusing on vaccine safety. Because he was so highly ideological and so much against government that he was determined to try to destroy people's faith in the immunization system. He had hearings, multiple hearings, and he brought in a star witness, Dr. Andrew Wakefield, whose research on measles vaccine had caused such a scare in the United Kingdom that measles outbreaks were occurring once again. Dr. Wakefield was the one, as we heard earlier today, who argued that immunizations cause autism. Now, this came at a time when there were rising cases of autism. Parents were certainly very fearful, justifiably so, that their children might become autistic. And when we had a congressman holding hearings to promote that point of view, it was like igniting a match. And that stuck with a lot of people until, a lie goes around the world a number of times before the truth catches on with it. That caused a lot of parents around the country to decide that they were not going to get their kids immunized. Certainly the Congress was playing, especially Congressman Burton, with matches. And even when we brought in the Institute of Medicine and the Center for Disease Control and all the scientific consensus that there was no connection whatsoever between immunizations and autism, he continued to repeat that lie over and over again. And in fact, I noticed in this last week that Chairman Burton was interviewed on CNN, where he again restated that immunizations cause autism. And he was relying on a study that was completely and utterly discredited. Propagating falsehoods about vaccines can have consequences, and we are now seeing those consequences. When it comes to the politics of whether immunizations are going to be mandated or whether there can be excuses for parents not to immunize their children, that has not been at the federal level, it's been at the local level. And I agreed with Dr. Sharfstein when he said it should stay at the local level, because the politics at the local level is to convince parents and the community that they must immunize their children. In my own state of California, in my own former congressional district of Santa Monica, there have been a large number of affluent people who did not get their children immunized because they had the ability to say they had a personal belief, not a religious belief, not a medical belief, but a personal belief. And this personal belief, for many of them, was exercised because they forgot what it was like. They never heard what it was like to have a measles outbreak. And therefore, they didn't bother to immunize their children, whether it was out of a personal belief or just plain laziness or fear. They had this belief and used it to not get their children immunized. My own state now is changing the law. Other states are going to change their laws. And I don't think it ought to be to say no reason should allow a parent's decision to trump the requirement for immunizations, because ultimately what we need to do is convince the parents that it's in their children's best interest to have them immunized. Well, my point to you from what I've seen over the years is that Democrats and Republicans have not only restored funding, we supported research into new groundbreaking vaccines. We had a sensible policy of vaccine liability and vaccine financing. We supported, through investigation of these allegations, that there were no vaccine safety problems. There was no connection between immunizations and autism and other medical problems. We've done it on a bipartisan basis. But we shouldn't lose our cool when one politician says something inappropriate about vaccines. There are consequences when people do that. They shouldn't be ignored, but there has to be a continuation of the bipartisan center that recognizes the value of the public health's greatest achievements through immunizations. Through this conference today, through the terrible news that we're hearing about, even more alarming as new results have been announced by the CDC just today, let us recognize that we have responsibilities to learn and to impress upon families that immunizations are a blessing. And it's a blessing, however, only if children do get immunized and parents have the responsibility, as do their communities, for their own children and others, that the immunizations take place. Thank you very much for allowing me to be here today.
Oh, sure. Thanks very much for that. I'll let you on this side please,
Okay.
with the mic.
Yeah.
But a couple questions for you. One is, the current Congress has been described as one of the most divisive Congresses ever. Do you have any worries that that divisiveness would threaten the partnership that you've described here that's existed around vaccination?
Well, I always have worries about that, and I've seen in recent years an increase in what we call science deniers, people who refuse to recognize science as based on evidence and reaching conclusions from the evidence. And I see more and more when you talk about climate change or these other matters that I mentioned earlier, that people dismiss the science if their ideology indicates that they can't otherwise deal with the conclusions from the science. So I worry about it. But we have not seen this yet in immunizations, except from a few irresponsible comments by a few politicians. I worry about it, but let's keep our heads about us and recognize that politics has intervened in the past, but we've overcome the politics by good, hard common sense and looking at the medical judgments of those who have done the studies and could give us their learned opinions.
You mentioned the issue of science denying. Mm-hmm. Many look to climate change as the big issue where you'll see a minority, but a segment of the conservative community that denies the science around climate change and distrusts government. On the other hand, when you look at vaccines and the issue there of science denial and distrust of government, many of those who are denying it on that side are highly educated, your community in Santa Monica. Mm-hmm. Do you see, liberals, do you see a parallel between the two issues and science denying, one an issue that resonates very strongly with the conservative community and one that is resonating very strongly with a more liberal community?
I think we have to recognize there's science denial by the conservatives because it's being driven by a financial interest for the carbon-based fuels, the coal industry, the oil industry, the Koch brothers who want to support candidates who will deny the science. And they advertise that the whole idea of climate change is a hoax. But they're wrong. But it's being driven by not just ideology, but financial gain for those who stand to benefit from this science denying. On the vaccine side, we have some conservatives and some liberals who are interjecting their points of view. But I think that without the financial backing of those who would stand to benefit, because who benefits? The healthcare system that's going to give care to people with measles? There's no financial benefit to denying the reality of how immunizations protect public health. I think that we can see that it's a different situation and that people are going to have to be educated. We have to recognize there are science deniers on the left as well as the right. There was an interesting article the other day in the newspaper where someone said, my liberal friends look down their nose at those who reject the science of climate change, yet if they're making motion pictures or video games that can influence children and give them a sense that violence is acceptable, aren't they denying the science as well? So being ignorant can be a consequence of people who are misinformed, whether they're on the left or the right, whether they're Democrats or Republicans. And I think we have to not let this be partisan, and there's no reason it should be partisan.
You talked about the Vaccine Compensation Act and its ability to bring more businesses in to create more vaccines. I've had people who worry about vaccines point to that system as evidence that vaccines are inherently dangerous, that we wouldn't need this system to compensate people if vaccines were safe. How do you balance those two perspectives?
The reason the vaccine compensation system was developed is not because there are many cases, but because there are few rare cases where there's an adverse reaction that is often quite horrible. And those cases are indeed rare, so the vaccine manufacturers worry about the liability and the lawsuits from those people. If they, rather than have them subject to enormous amounts of money to go into litigation, we said, let's compensate these people. But it is extremely rare, and the best evidence of how rare it is that we set up a compensation system with a tax on the vaccine that ran a surplus. When we had a rare adverse reaction, there was a compensation given without all the efforts that a lawsuit would have to mean for the person to be compensated or the drug company to defend against it. And when the compensation was given, the compensation was accepted almost always instead of going into the court. But it's not because it was a common problem, it was because it was a rare problem that was threatening the manufacturers into thinking that maybe they ought to stay out of this particular line of medical production.
And just one last question. With such a long career in Congress, when you look back on your legacy around health, what are you proudest of?
Well, I'm proud of many things that I've done in the health and the environmental and other areas, and I wouldn't want to single out any particular one issue. But I would say that I'm proud that we were able to show that government is important in the lives of the American people, and we take for granted things that we have to recognize were often hard fights in Congress. We take for granted, for example, that we can read information on the labels of products to know the nutrition, so we can handle our own diets. People would say, of course. But that came about over many years. We fought the tobacco companies and got legislation to give FDA authority to regulate them. That was 14 years later than when the CEOs testified and lied about cigarettes causing disease. We had other common sense bills almost always took time to deal with the HIV/AIDS epidemic, to develop the response from the Ryan-White Act. All of those bills were bipartisan, except one, and that was the Affordable Care Act. And it shouldn't have been partisan, except for the fact, in my view, that the Republicans who had given the original ideas for the creation of this way of dealing with the health care insurance problem decided that they weren't going to give President Obama any chance for any victory. But otherwise, all the bills that I've been involved in have been helpful, important in people's lives, whether it's immunizations or disease screening or dealing with various diseases. They're important, but they were not easy. And we have to keep that perspective in mind to understand the legislative process moves slowly, but when it accomplishes important goals, it is very, very important for the American people.
Thanks very much.
Thank you.
Lastly, I want to introduce again Dr. Lena Wen. She's an emergency department physician who is now the new Baltimore City Commissioner of Health, a former Rhodes Scholar. She's author of a book and has lectured widely on the topic of patient-doctor communication and transparency in medicine. And she's here with some others to make a big announcement.
Good morning, everyone. On behalf of Baltimore Mayor Stephanie Rawlings Blake, I wish to thank Dean Clegg, Associate Dean Sharpstein, and the Bloomberg School of Public Health for hosting this outstanding symposium today. And I also want to thank Congressman Waxman and our many doctors and scientists who have spoken today for your leadership and for working every day to advance science so that we can protect our public. We stand here as pediatricians and public health leaders of Baltimore City and County to express our solidarity on the importance of childhood vaccination. Let me take us back to the 1930s. There was a measles outbreak right here in Baltimore, right here where we're sitting, that sickened thousands of our children, that killed or permanently injured hundreds in our city. Families lived with uncertainty and fear, not knowing when illness and tragedy would strike us. Thanks to the invention of vaccines, as we heard today, we're fortunate to live in an era where many of us have never seen the devastation of diseases like measles. For the last 10 years, we have had 0 cases of measles in Baltimore. That means 0 deaths, 0 injuries, 0 hurt children, 0 tragic families. We have come so far, only to see measles take hold again. If it's a lesson from everyone today, it's that we cannot be complacent. As individual doctors, we have been advising our patients to make sure that children are vaccinated. Today, our region's doctors have come together to make a joint statement. The Baltimore Statement on Childhood Vaccinations is our united stand against measles. Johns Hopkins, the University of Maryland, St. Joseph Medical Center, Mercy Medical Center, Sinai Hospital, Harbor Hospital, St. Agnes Hospital, Greater Baltimore Medical Center, and MedStar Franklin Square. These are the institutions with their leading pediatricians standing with the health departments of Baltimore City and Baltimore County and the Maryland chapter of the American Academy of Pediatrics. Ours is an unequivocal message. Vaccines are safe, they're effective, and they save lives every single day. When we as individual doctors speak with our patients about vaccines, it's about the one-to-one relationship and improving that individual's health. When we as the region's doctors speak to the public about vaccines, it's about more than the individual's health. It's about the health of our community. It's about our mutual obligation to one another. It's about the value of vaccines to safeguard the future of Baltimore. I'd like to now introduce 2 of our area's distinguished pediatricians to explain why they have signed on to the Baltimore Statement on Childhood Vaccinations. First is Dr. Stephen Zinn, the Chairman of Pediatrics at the University of Maryland School of Medicine. Dr. Zinn.
Well, thank you, and I want to really thank Dr. Wen for bringing this whole group together today for such an important issue. I am a pediatrician, but I'm also a parent of 4 beautiful children. As parents, we have an obligation, we have a responsibility to keep our children out of harm's way. And so I'd like to address my comments to the parents who have not vaccinated their children or who are thinking about not vaccinating their children against measles. I ask you to contact your healthcare providers today. I ask you to objectively review the information with your healthcare provider. The oft-cited study that suggests that there are complications to the measles vaccine and potentially cause autism was so flawed and so misrepresented the data that the journal that published it had to take the unusual step of publicly retracting that paper. I ask you to review the data. There have been dozens of studies in the last 10 years that demonstrate the safety and efficacy of these vaccines. If you do that, common sense will dictate that you need to get your children vaccinated. You need to get your children immunized. You need to keep your children out of harm's way. Vaccinating your children will not only protect them from measles, but it will also protect the other children in your community who are either too young to be vaccinated or have other medical conditions that don't allow them to be vaccinated. It's the right thing to do, and the data supports it. Thank you.
Thank you, Dr. Zinn. And now we have Dr. Joseph Wiley, the Chief of Pediatrics at Sinai Hospital.
Thank you, Dr. Wen, and I appreciate all of the comments that have happened before I got here. Especially delighted to see my good colleague and friend, Dr. Sharfstein, who worked for Congressman Waxman. I am a pediatric physician, but I'm also a pediatric oncologist. That means that I take care of children who are vulnerable because of their condition and the therapy that we give them, perhaps among the most vulnerable that we care for. They have a lot to go through in terms of dealing with their illness. I don't want them to have the fear that because of their illness, they're going to be at risk for contracting an illness that is vaccine preventable. As has been so eloquently said by our friend in politics, vaccines have made the biggest difference in the history of the planet in terms of illness, right there next to hygiene and other things. We have an obligation to protect our children, as Dr. Zinn has so well said. I haven't missed a day of work from illness in 31 years, but the sickest I ever was in my life was when I was 5 years old and I had measles. I would never want to see anyone go through that. We have the ability to prevent that from happening in the future to our children. I think that we all have an obligation to help each other understand the right path forward. And rather than take stands against each other, we need to walk forward to make sure that this is one of many issues that we address now and forever for our children and for our society. So thank you, Dr. Wen, for bringing us here together.
Thank you, Dr. Wiley. I express my gratitude on behalf of Baltimore Mayor Stephanie Rawlings-Blake and the Baltimore City Health Department. We are honored to bring together our region's pediatricians and public health leaders to take a stand against measles. We in Baltimore don't want to wait until it's too late. We do not take a back seat to public health. We educate to improve health. We tackle myths and misinformation. We lead with science and evidence. We urge health leaders in every city across the U.S. to join Baltimore to prevent measles from rising again. Thank you.
Well, that's going to conclude our program. I hope, first I want to thank all of our speakers today for sharing their knowledge, their information, answering some tough questions. Hopefully today, people have learned what's driving the current rise in measles in this country. We have a choice to make whether the curve for measles continues to go up, whether this becomes not just the worst month of measles in the past 20-odd years, whether it's the worst year, whether measles is a disease that parents will now have to experience. But there is a choice to make, and hopefully the information that you've heard today will help you make that informed choice. For those who are healthcare providers, help you deal with your patients and the many concerns and valid concerns that parents have as they try and do the right thing for their children's health. So thank you all very much, and thanks to Johns Hopkins Bloomberg School for convening this session. Thank you.